Malaysia reported 3,000 new COVID-19 cases today, its highest daily number ever. This comes as
COVID-19, pemerintah Malaysia memutuskan memperpanjang lockdown hingga akhir 2000.
Minggu lepas pun membimbangkan, tapi terutamanya 2 hari lepas 5,700 lebih kes. Hari ini kita pecahkan rekod sekali lagi. Sebelum ini KKM mengatakan bahawa PKP.
Lalu bagaimana nasib warga negara Indonesia yang saat ini berada di Malaysia? Untuk mengetahuinya, kami sudah terhubung dengan Ketua Umum Perhimpunan Pelajar Indonesia di Kuala Lumpur, Malaysia, Muhammad.
It is now 14:25, 100 hours Malaysian time. Let us begin our event today. A very good afternoon to all of our honorable speakers and distinguished guests, as well as to our locals and foreign participants. On behalf of the organizers, I would like to extend my warm welcome to all webinar participants and thank everyone for allotting time amidst your busy schedule to attend today's event. Welcome to the third pre-conference webinar installment of the Malaysia Military Medicine Conference 2021 in partnership with Defence Service Asia and AeroC Exhibition Sdn Bhd. Without further ado, allow me to introduce today's webinar moderator, Brigadier General Dr. Rosman Abdul Rahman. Dr. Rosman is a consultant in internal medicine with over 20 years of experience in the Malaysian Armed Forces Hospital. He also holds a diploma in aviation medicine from the Royal College of Physicians, London, as well as an MBA from Ballarat University, Australia. He is currently the Inspector General of Health Services Division, Malaysian Armed Forces for the past 5 years, whose main duty is to ensure the quality and standard of medical services delivered throughout the MEF. With that, I would like to invite Dr. Rosman Abdul Rahman to moderate this event. Please welcome Dr. Rosman.
Thank you, Dr. Shazni, for your kind introduction. For everyone's information, Lieutenant Colonel Dr. Shazni is one of our OND specialists at Tuanku Mizan Armed Forces Hospital in Kuala Lumpur. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi and a very good afternoon to all. Welcome to our very inclusive conference on very important disease, COVID-19, turning challenges into opportunities. This is jointly organized by the Malaysian Armed Forces Health Services, Defence Services Asia, NATSEC Asia, and AeroC Exhibition Sdn Bhd. This is actually the third of a series of 6 pre-conference webinars to this year's Malaysia Military Medicine Conference. The Malaysia Military Medicine Conference, MMMC in short, is a conference organized by the Malaysian Armed Forces Health Services on the specialty of military medicine. It covers aviation, operational, and undersea medicine, and is an avenue to discuss topics specifically bearing upon problems of military medical interests, such as improvement in human performance, both in normal and in harsh working environment, the logistical and administrative considerations of establishing and operating field hospitals or combat support hospitals, and the related public health issues, trauma vis-a-vis mass battlefield casualties, including massive blood transfusion at the front line, and medical research and development in problems with military medical interests. There are breakout sessions for discussions on focus areas of medicine, dentistry, pharmacy and medical logistics, veterinary, paramedics, as well as ICT. The MMMC is a biannual event. It is open to everyone, not just military personnel. And for those of you out there who are interested to join, it carries 20 CPD points. This year, it will be held on the 5th and the 6th of April. Back to today's webinar. The COVID-19 pandemic has changed our lives in many ways, exempting no one. Gone are the days when we can travel freely. We now have to observe physical distancing, wear masks, and become less social in our daily lives. And we have been in and out of NCOs, especially here in the Klang Valley a few times. Is there light at the end of the tunnel? The answer is yes, God willing. If everything goes as planned, by this time next year, most of us will be vaccinated and we will have achieved our herd immunity, and life as we knew it may be back, albeit with a host of new norms. Every cloud has a silver lining. This pandemic, which has made us stay indoors, has also forced us to acquire new skills and adopt new ways of working and communicating. We are now forced to be more technology savvy, and many people have become literate in ICT, although with a steep learning curve. We found out that for some jobs, non-clinical especially, you don't have to be physically in the office. Well, we sort of knew about this and the bosses knew about this. But now we are forced to embrace it, and with not much problems really, other than boredom from being at home for too long for many of my friends that I know. We do our shoppings and even buy meals online, and our children attend schools virtually. The list doesn't stop here, and today we will hear from the experts what other opportunities have arisen out of this pandemic, such as the lesson learned from this pandemic and our way forward, the improved interagencies cooperation in this country in handling pandemic of this size and scale since the arrival of COVID-19, lab advances to monitor the present and detect future threats, innovations in vaccine, and technology utilization in healthcare delivery, especially data networking and Internet of Things for preventive healthcare. After all, COVID-19 is certainly not the last virus to threaten mankind. We will have 5 distinguished speakers presenting and sharing their experiences and ideas on turning these challenges on different aspects of the COVID-19 pandemic into opportunities. I shall introduce them in due course. The first 2 speakers will present for 30 minutes and there will be no question and answer. The subsequent 3 speakers will present for 20 minutes, followed by 10 minutes question and answer each. Participants are welcome to post questions via the question box, and we will try our very best to address as many questions as possible in the limited time. It is now time for the first speaker. Lieutenant General Datuk Pahlawan Dr. Muhammad Amin bin Muslan is the Director General of the Malaysian Armed Forces Health Services Division. He graduated from the University of Malaya and joined the Royal Medical and Dental Corps, Malaysian Armed Forces in August 1987. In the course of his service, he has attended multiple professional and military training courses in the country and abroad. And in 1996, he received his Master in Occupational Medicine from NUS Singapore. He has extensive experience in military and humanitarian operations, having served over the years in various appointments at regiment, brigade, division, hospital, and headquarter levels. He was involved in several operations extending from counterinsurgencies, peacekeeping, counterterrorism and piracy, as well as humanitarian missions, both in the country and abroad. Notable and relevant ones are the humanitarian aid program in Yogyakarta earthquake, tsunami hit Aceh, and peacekeeping mission under the United Nations in Namibia. He was appointed the DG of Malaysian Armed Forces Health Services Division on the 17th of January, 2019. With his vast experience in interagencies cooperation, he certainly is qualified to talk to us on the role of other agencies and NGOs in a pandemic response. I hereby invite Datuk Dr. Muhammad Amin to present his talk.
First and foremost, thank you for that very kind welcome and also a very kind words about me. As the Director General of the Malaysian Armed Forces Health Service, I take this opportunity to express our appreciation for the guidance and leadership to our Colonel-in-Chief, His Highness Sultan of Perak, Sultan Nazrin Muizzuddin Shah, Ibni Almarhum Sultan Azlan Muhibbuddin Shah Al-Makfula, His Excellency, the Minister of Defence of Malaysia, Dato Sri Ismail Sabri bin Yaakob, the Most Honorable Tan Sri Dato Sri Panglima Apindi bin Buang, the Chief of Defence Force, Malaysian Armed Forces. I also take this opportunity to thank DSA for this opportunity to participate in a webinar that I was made to understand have almost about 1,000 over participants. And last but not least, I would like to thank all the panelists for this evening. First and foremost, Tan Sri Dato Sri Dr. Noor Hisham bin Abdullah, the COVID man of Malaysia. Dr. Ravichandran Tayan from IMAR, Institute of Medical Research, Malaysia. Professor Dr. Ugan Kurel, who will be talking about immunity and the challenges that we are expecting from the vaccine. And Mr. Stuart Peck, a very experienced healthcare entrepreneur, healthcare manager, who will talk about the challenges with technology in addressing this pandemic. Ladies and gentlemen, globally, there have been more than 6 million confirmed cases of COVID-19 charted in June 2020. This is about 8 months ago. And to date, the numbers have risen to more than 111 million cases of COVID-infected people with 2 million deaths. This has shown how COVID-19 has been a raging pandemic triggered by national emergency in many countries. Unprecedented restrictions were enforced not only on the movement of people, but also on a range of economic activities. This disease does not only cost life, but is also causing livelihood. Growing demand for urgent healthcare and rising death toll are straining national healthcare system and also their economic reserve. Much less, or I would say much more, is the political resilience of each nation. The pandemic is disrupting global supply chain and international trade, with nearly 100 countries closing national borders during the past month. And Malaysia has still continued to have restriction on its border entry. The movement of people and tourism flows have come to almost a screeching halt. More than 2.2 billion workers live in countries where workplaces have been closed. According to the ILO estimate, 436 million enterprises are in high-risk sectors. Example, manufacturing, food, lodging services, real estate, wholesale, and retail trade. The ILO estimate a loss of 305 million jobs worldwide. Next. Are we at war? Yes, the nation is at war. Next. But it is a different kind of war. This is a war that started from a public health crisis. Unlike other wars, which is very easy to identify, we here are not very clear. Who are we at war with? Are we at war with the virus, or are we at war with ourselves? Success depends on how well we respond to this threat. Next. So the roles of other agencies in COVID-19 pandemic is basically in helping to save life and also to save livelihood. And in a war, you need to use all the national element of power, be it political, social, education, technology, security, economics, and everything. We must garner our strength to address this threat. Next. As I mentioned, this is a public health crisis. The threat that we are facing is a health threat. It affects population health and also public safety. In health, directly, it increased mortality and morbidity. As I had mentioned earlier, the mortality and morbidity have risen in many folds. In June, we only have about 6 million cases, but now in February 2021, we are facing almost about 111 million cases, with 2 million deaths recorded due to COVID. In health, indirectly, this pandemic is sharpening a lot of health resources. Many countries are already burdened and vulnerable to the strain of the healthcare system. COVID-19 just makes it worse. The other part is also in economy. How economy affect health and how health affect economy has well been known. Good health means good economy. Poor health means poor economy, and vice versa. The movie Outbreak has given a good description how a pandemic would turn out. It was a movie in the 1990s, and here in the year 2021 or starting 2019, we have seen it again. The earlier scare of SARS, MERS are only the prodromal of this current pandemic. Next. As mentioned, this is a public health crisis. That is a threat. But unfortunately, this threat is still yet to be determined. After 1 year, WHO has only just finished its study in Wuhan, China. We have yet to know what is the actual cause of this disease. Is it laboratory engineered virus, or is it something that occurs naturally? Public health measures that is used to counter this threat are very disruptive and on the livelihood and can cause political instability. And about the virus itself and the disease itself, there's much that we still don't know. So this is the challenge that we are faced today. Next. In Malaysia, the War Room is the National Security Council. This is a place where strong political will and support is necessary for an efficient response. Malaysia has been very lucky to have the commitment of its leaders in the National Security Council. In my 32 years of service in the Malaysian Armed Forces, I had never seen such devotion and commitment by the Malaysian government, cabinet ministers, in addressing this threat. The Prime Minister himself said almost every day, or if not every other day, to be briefed by the technical committees on the development and the result of mitigation effort taken by the country. Such devotion, such commitment need to be applauded because it's just mere for the love of the nation. Next. The role of the Security Council is assessing the threat to life and livelihood. It is to determine the strategic national and state of the public health condition. It is the place where coordination of allocation of national resources is going to be done. And it is also how we nationally respond and how our relation with the foreign countries and also our strategic allowance. Next. Its only purpose is basically ensuring national security. This cartoon was taken somewhere in April in one of the news. This cartoon depicts how COVID-19 is not a disease due to a virus, but also a disease complicated by virals. There's a lot of fear mongering happening around, made worse by the then geopolitical situation between the two world powers. In December 2019 till March 2020, we have yet to ascertain how the world power going to respond to COVID-19. A lot of finger pointing happening and a lot of confusion is resulting from those finger pointing. So the description of this war is actually very, very challenging. You have a very clear virus affecting people, a very new virus affecting people. You have the advance of technology available, but you have different perception and understanding confused by states, social medias, and also individuals. Next. So this public health crisis, and for Malaysia, what I can list is some of our vulnerability. In Malaysia, at that time, we are actually undergoing a very challenged political situation. The starting off of the pandemic resulted in the change of government, and this resulted in the level of public trust. This is not good situation in addressing a public health crisis. At that time, we have a very challenged public health system of surveillance, detection, and treatment. Although in September 2019, we just underwent the International Health Regulation Review, external examiner review of our health system, and we were commended of the very good system that we have. But we have yet to pick up on some of the recommendations that has been made by those external evaluation. One of it is the aspect of either agency working toward addressing public health crisis. Third, the crisis management system to contain the spread of the virus. Malaysia have yet to face major public health issues like the COVID-19. Yes, we have been very successful in managing the Nipah outbreak, the dengue outbreak, but for a virus that is very new and have a very high potential to strain the health system, this is very new for us. Malaysia is also faced with poor control of urbanization and industrialization. COVID-19 is a disease that attacks social ill, like crowding, like poor ill health, like poverty. And Malaysia is still trying to overcome that. Industrialization in Malaysia has resulted in a lot of foreign workers in the country. And issues of managing foreign workers has been a major problem while we are facing this outbreak. Fifth, Malaysia has a very large border with its neighbor. We have a large coastline with Indonesia, the Philippines, and issues of transmigration has always been there. Documented migrants are much easier to manage, but undocumented migrants are a big challenge. Migrant workers has always been part of the ill of industrialization. The other thing is economic resilience. During the change of government, obviously there is an impact on Malaysia's economic progress. COVID-19 will strain the economic resilience of a nation, and we can see later on how Malaysia addressed that. Next. So in assuring national security in public health crisis, I will try to bring you through the progress of how the National Security Council has managed. In the earlier part, barely in the month of February, during the previous government, COVID-19 is still new. Our first recorded cases in 18 February. But due to worldwide concern, Malaysia had tried to address this issue through the National Disaster Committee, headed by the Deputy Prime Minister then. During this time, the National Agency for Disaster Management has taken the lead to manage COVID-19 outbreak in Malaysia. NADMA has been very instrumental in assisting the Ministry of Health with all the non-MOH requirement. For example, logistic, PPEs, and others. When we have the major outbreak involving a group of religious group, suddenly Malaysia have seen the first big wave involving almost about 16,000 people who are participating in that group. The nature of this religious group resulted in massive dispersion of COVID-19 into this country. It not only involved Malaysia, but it also involved some countries like Brunei and also India. That is a time where COVID-19 is labeled as a national crisis. And the operation for managing COVID was then transferred to the National Security Council. During this time, we have implemented harsh measures managing the disease, and we have been very successful until we are in the month of December. Suddenly, the number of cases started to rise. We have seen cases up to a level of 5,000 a day, of which is straining the national health system. At that time, we need political stability. We need the government to function efficiently. As such, a proclamation of a national emergency for the management of COVID has been declared by the King. This is basically to assist the government in ensuring that all the national resources and the one nation approach can be implemented effectively to ensure that the country can overcome this challenge of managing COVID-19. We have yet to see the effect, although we are seeing some effect right now. Cases start to become lower than 3,000. Next. So let me elaborate. Since this is a public health crisis, the essence of managing a public health crisis. Tom Frieden, the US public health specialist, has described, to manage a public health crisis, you must be scientifically competent. Everything you do must be evidence-based. And you must rely on your health community capital, the people, and also the infrastructure. Whatever you do in a public health crisis, never go beyond what is scientifically proven. Many nations have had difficult experience when they did not follow what is scientifically possible. We too have some challenges in the past, but COVID-19 is a very new disease. There's so much that we know, and there's a lot more that we don't know. Till now, people still argue how accurate is the PCR test? What should be the baseline? What should be the gold standard for testing? The second thing is you must be operational competence. In a crisis, you must be able to build surge capacity and to organize resources to meet the demand of the health community. Only then you will be able to manage the crisis well. Apart from it, you must also be operationally competent to address other non-health impact of the crisis, like social, economic, religious, that have caused by this disease. As I mentioned, this is a disease not only causes death, but it also causes disruption in the normal social lifestyle. And third but not least, to be able to do A and B above, you must be politically competent. Perception management is very important to avoid panic. Public trust is important to ensure that every members of the community understand what is being done and able to do what they are supposed to do. Without a politically competent organization, you won't be able to achieve this, especially now where COVID-19 is still a very new disease. A lot of misinformation can happen. A lot of opportunity can also be taken up by untrusted element to derail whatever the government is doing. Next. So the role of other agencies, of which later on Dr. Nur Hisham will explain on KKM role, I will only touch on the role of other agencies. We can divide it into health-related, or basically to save life, or non-health-related activities, which is to save livelihood. Okay, next. In the first one, in saving life, apart from the Ministry of Health, other agencies have been assisting in bolstering the surge capacity of MOH. What's shown here is an innovative, makeshift low-risk COVID treatment centers that need to be raised to address the rising numbers of COVID-19 cases. Malaysia at that time is faced with the challenge of having an efficient home surveillance order implementation. So to avoid transmission of cases in the communities, the government has decided that all COVID-19 cases will be staged at quarantine centers and managed at the quarantine centers. And this is among one of the biggest quarantine centers. Okay, here we see MOH people, medics and doctors from the armed forces, security personnel from the police, the other law enforcement agencies working together in trying to achieve a very difficult environment where you have to manage COVID-19 cases, felonies from prison, and also illegal immigrants. Next. These are the inside. Okay. And to be able to do this, all agencies need to have the ability to adapt and adopt new cultures. Innovation is key to this creativity. Next. These are another centers that we have to open up during the third wave in Tawau, Sabah, when the state of Sabah suddenly see a tsunami of COVID-19 cases. So the armed forces have been critical in assisting the MOH in setting up makeshift treatment centers. And this comes naturally from an organization that is supposed to be working in the most austere environment. But we too learn from the Ministry of Health aspect of managing COVID cases so that the risk is lessened to our personnel. Next. Not only by setting up treatment centers, we also assist the district health office in ensuring public health measures is taken up. Example, screening of cases, chasing off contact tracing, and also managing cases at the district level. Next. The other thing is implementing the movement control orders. Here, the armed forces and the police, and also other enforcement agencies like RELA, APMM, and JIM also work together to ensure that everybody follows what being ordered by the National Security Council. Next. The Malaysian Armed Forces chemical, biological, radiological threat element is also being deployed to assist and to train in terms of decontamination and also in ensuring the proper managing of contamination at the various center. Next. This is interesting, whereby the Ministry of Local Government utilizing its element, especially people from the fire department, in doing decontamination at public places. Next. And of late, we are seeing the Ministry of Health spearheading coordination between all health communities in the nation, especially the private hospital, for treatment facilities and also for laboratories facilities. Next. Obviously, there is a role for NGO. Malaysia is blessed to have many health-related NGOs like IMARED, okay? And they have been forthcoming in assisting to fill up gaps in areas where there are shortcomings. COVID-19 is a disease that can cause sudden rise in cases. And Malaysia have seen that in the past few months. And having NGOs to assist in addressing this need for sudden surge is very, very much helpful. Next. The health communities also appreciate the work and role by the industries by creating innovation like these catering robots, and also by people who are addressing the need for PPEs. So in a war, everybody must chip in. But what's important basically, how do you coordinate this thing into a very worthwhile effort? And this is where NATMA and the National Security Council, with the guidance of Ministry of Health, has been very successful in it. Next. Another that comes from the industry is the MySejahtera apps that help in contact tracing and also advise individual of their COVID-19 risk. This technology is now being adopted by the government, and now we become the next platform for tracking. So it just shows that how everybody can assist in managing this COVID-19 pandemic. Next. Now let's go to the non-health related. COVID-19 not only affect the economy, it also affect the social and livelihood of the people. Next. On the economy sectors, MOSTI, MITI, MOTEC, and the industry players has been very innovative. As mentioned by the ILO report, workers and workplace will be the place where COVID will hover and make people vulnerable. Industries have been very creative in addressing work by introducing work from home and also online services. During this pandemic, we see industries like Grab, online commerce, and also online teaching, helping people in overcoming. Next. This is particularly unique for Malaysia. There is worker safety and worker welfare. Malaysia has about 800,000 foreign workers registered, and it is expected that there will be about another 800,000 unregistered foreign workers. This is the result of industrialization, the result of urbanization. Workers' housing is a major problem. And this is where COVID is at its most dangerous point. Malaysia have seen a lot of outbreak happening at workplace. And this is very challenging, where you balance between life and livelihood. Obviously, a responsible government will choose life, but there must be sacrifices, and it must be from the employer or the employee. So we are still addressing these challenges. We hope the Ministry of Human Resource will continue taking the effort and be guided by the Ministry of Health. Yeah, and NIOSH, which is an agent under the Ministry of Human Resource, is of very much important to ensure that this problem is addressed. Next. When you talk about social impact, there's nothing more than I can say is financial and social safety. Yes. Here, the Ministry of Finance has been very blessed in providing various support packages for individual and also for industries. The support services have been creative, and the latest one is ICNA, whereby to help reduce the impact of COVID-19 on individual and organizational economic. We hope that we will be able to sustain the economy and also the society until we come to an acceptable solution to this pandemic. At the same time, mental health issues and social issues is a challenge. Working from home bring up new challenges. Mothers need to stay at home. Children have to stay with parents. These are new things that we are supposed to address now. Next. Of late, the education sector is among sectors that have been involved a lot. School, universities has been conducting online courses, and with Malaysia limited infrastructure and the forced system of alternative education, this is something that is very challenging. Malaysia will be facing its major exam, the Malaysian Certificate of Education exam, and this will be a test on how well we have been successful in managing the impact of COVID on education. Next. The legal system has been very instrumental. It has been very useful when we address it during the disaster. It has much usefulness when we try to address all the viral misinformation that is affected by this crisis. It is also very useful in empowering health enforcement agencies and also in ensuring that professionals are protected when they carry on their duties. It is also very essential to ensure that economics burden will not be complicated by industries due to issues of contracts that is not being able to be met. So the legal system is an essential aspect of managing COVID-19. Next. Another thing is that ensuring that our borders are well taken care of. In the past, the management of borders are under various agencies operating in silos within each agency. During COVID-19, the Malaysian Armed Forces had been given the task to manage and coordinate all enforcement effort against illegal immigration and border entry. So far, this task force has been successful in getting each agency to focus on which area of challenge. We hope to see more outcome from this national task force. Next. The role of NGOs cannot be overstated. Obviously, there will be areas whereby government will not be able to keep up with the need of the populace. This is where the NGOs can be of utility to address this thing. And Malaysia is blessed by having so many NGOs. But managing so many NGOs in addressing COVID-19 come with its challenges too, as COVID-19 can also pose a threat to NGO. Malaysia has a big challenge in managing this and successfully addressed it during the last disaster of flood that we faced a few months ago. So far, we did not have increase in COVID-19 cases involving NGOs that helped during the flood outbreak. Next. As I mentioned, there's a lot of role for NGOs, and they can be involved in the health-related activities or the non-health-related activities, basically in relieving the impact on economy and also the lifestyle of those affected by COVID-19. Next. Not only in Malaysia, Malaysian NGO had also been very instrumental in helping other humanitarian efforts out of the countries. Okay, next. So, as I can summarize, the role of NGO is a role that to ensure that no one is left behind. Next. So what can we learn? First, we must build resiliency. Only with resiliency that we can manage any threat that will come. COVID-19 is only one of many that I'm sure will come again. Second, not just stop at the new normal, but we have to grow into a better normal. A new normal might not be the best for the future. A new normal is just an adaptation, but we need to build better normal so that we can also build resiliency. Third, we must invest in disaster and crisis management. We have challenge in the first phase of COVID-19, but I'm sure after or post-COVID-19, we need to invest more into disaster and crisis management and look into the issues of building our surge capacity. COVID-19 has exposed our vulnerability in terms of supply chain, and these are areas that we need to address to ensure that there won't be any repeat of similar crisis in the future. Fourth, we need to invest in health and better integrate our healthcare capitals and healthcare services to ensure accessibility and coverage for all Malaysians. Malaysians still have very high numbers of pay out-of-pocket payment, and disease like the pandemic will obviously cause poverty rampantly. We must also advocate sustainable industrialization and also urbanization. Urban planning is important. Housing, and especially workers' housing, need to be addressed systematically and not to be allowed to the market forces to determine. And last but not least, we must invest in our social capital. In the public health crisis, we need everybody to stay together, work together, fight together, and have the same hope of getting better together. Social capital, social integration, and political stability is crucial to ensure that the effectiveness of all measures will be able to be implemented. Next. So before I end, allow me to take this opportunity to thank all those agencies, organizations, enterprises, individuals that have contributed to the nation fight against COVID-19. The various ministries with their various roles, the various departments that have undertaken more than they're supposed to do, the industries that have keep on listening to the government, helping and trying to persevere through the hardship, the doctors, the nurses, the laboratories, and also the NGOs. You are all our heroes. We need you all in this war, and together we can win this war. Thank you very much.
Thank you, Dato', for the very informative roundup on the various challenges faced by the nations in the early phases of the pandemic, both in health as well as non-health, both in health and non-health sectors, the essence of managing a public health crisis, and the roles government agencies and NGOs play during pandemic, and how crucial this interagency cooperation is to ensure the success of a national pandemic response. Also, you mentioned the importance of the National Task Force and its leadership, and touched on the lessons learned, especially in resiliency and capacity building, as well as investment in health system, social and political stability to win over this pandemic. As mentioned earlier, there is no question and answers for this session. Now to our keynote speaker. Since the start of the COVID-19 pandemic in this country, more than a year ago, one face has become very familiar to all Malaysians. He would appear on TV almost daily and present the latest tally and answer questions on the pandemic. He's none other than Tan Sri Dato' Sri Dr. Nur Hisham Abdullah, the Director General of Health Malaysia. Tan Sri Dr. Nur Hisham needs no further introduction. However, I will just mention that he is a senior consultant surgeon with expertise in breast and endocrine cancer surgery, and has numerous published papers and textbook chapters in this subject. He chairs multiple medical professional councils and national level technical committees, and is actively involved as a policymaker in global organizations such as the WHO and the Drugs for Neglected Diseases Initiative. He is also a counselor at large in the executive board of the International Society of Surgery, the ISS, and chairs the Global Surgery Committee of ISS. In March 2020, he was elected as the chairman of the Asian Association of Endocrine Surgeons. Tan Sri Dr. Noor Hisham has been conferred numerous local and international awards, including the prestigious Fellowship ad hominem of the Royal College of Surgeons of Edinburgh in 2018 for his contributions towards healthcare. For his exemplary leadership in managing the healthcare sector's response in the COVID-19 pandemic, he was named the National Ma'al Hijrah Figure of 2020. Tan Sri Dr. Noor Hisham will share with us the nation's experience, strategies, and way forward in combating COVID-19 in his keynote address entitled COVID-19 Pandemic Response in Malaysia, A Journey Well Traveled.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a good day. First and foremost, I would like to thank the Ministry of Defense for giving me this opportunity to share the COVID-19 pandemic response in Malaysia, and a journey well traveled so far. We hope to end this journey as soon as possible if we have the vaccine, or even if we can have other measures to contain the infection. Next slide, please. Now, over the last couple of months, we have been stepping up our preparation as well as our fight against COVID-19. And to date, confirmed cases globally is 106 million. And in Malaysia, we had 248,000 cases been reported. Death rate globally is 2.3 million, and our census in Malaysia is 909. So the first case in Wuhan was detected late in 2019. We had our first case on the 25th of January 2020. And since then, we have 3 waves. The first wave started from 25th of January until 16th of February 2020. And then we have 11 days without cases, and we started our second wave on the 27th of February onwards, and until 16th of July, and that was our second wave. Then we have a period of 2 months without cases. Our minimal cases, single digits and lower double digit. And when it came on to 20th of September, we started having our third wave following the by-election in Sabah, and that's where I think cases are our very challenging third wave. And although we are more prepared than before, but the third wave is more challenging than the second and the first wave. Next. And this is the slide showing the pandemic waves in Malaysia. Pre-pandemic, 0 cases so that is our benchmark at that point of time. Then when the first wave came on the 25th of January, when we have imported cases, we have 22 cases in the first wave, and mainly all related to tourists from China, directly or indirectly infecting the local. For example, 6 of our local individuals have been infected, and the genomic studies have shown that at that point of time, the virus comes from Wuhan, China. And then when we started our second wave, there we will be challenged by Sri Petaling cluster, that is from the Jemaah Tabligh, and also the Immigration Detention Center. And then we see a change in terms of the virus here, because it's more towards a C strain that is coming from Indonesia. At that point of gathering in Sri Petaling, we have 15,000 people gathered in this mosque, and 1,500 foreign participants, and 694 participants from Indonesia. Then when we started the second wave, we also have started our lockdown on the 18th of March, and it went on until July, 16th of July. And then our baseline at that point of time is not 0, but we have calculated our baseline is lower double digit or single digit. So our average line of baseline is 25 cases. So until we reach on the 20th of September, then you can see the beginning of the third wave, which is more challenging related to the clusters in Sabah, Kedah, Selangor, and also foreign worker screening program. And some of cases are coming from detention centers and prisons. Next. So these are the pandemic waves in Malaysia. So if you can compare the first wave, second wave, we did well in the first wave and the second wave, and we managed to flatten the curve on the 14th of April 2020, following our MCO order on the 18th of March. It takes about 4 weeks before we can flatten. And because during that period of time, the festive season of Ramadan as well as Hari Raya is coming, so we continue another 2 weeks until May during our lockdown. And then we change our strategy because change our strategy from MCO to CMCO. The cost of MCO at the point of time, we were informed about 2.4 billion ringgit a day. So we have to change our strategy to CMCO, whereby to allow the economic sector to function, but to control the social, education and sports sector. And we managed to contain the infection well following the CMCO until 9th of June. So we switched to the RMCO, Recovery and Movement Control Order. And this is important for us to resume back to all activities, social, economic, education, as well as sports. But they have to comply to the SOP. So we were doing quite well until August. We were seeing basically the RMCO two digits, lower 2 digits, even single digits, and we have a period of time, 3 days, we have 0 cases being documented. And at that point of time, I think it's important for us to have tightened the border control, but more importantly is the compliance and discipline to the SOP. And when we, in March, in September, for example, during the campaign, political rallies and etc., the compliance and the discipline to the SOP were relaxed. And that's where we see the surge of cases following the Sabah state election. And now we are in a very challenging time to try our best again to flatten the curve. But during this period of time, I think it is also important for us to look back what we have done right and what we have not. And from the experience that we had, and because we need to balance between life and livelihood, so instead of going for MCO in Klang Valley, already we projected that there will be surge of cases in Klang Valley following the election in Sabah. But nonetheless, because of, to balance health and economy, we decided to go for CMCO instead of MCO. And certainly, CMCO has managed to contain and even control the exponential surge, but we are not able to bring down the cases or even the R0 to less than 0.5. And I think, and that at that point of time, we also realized that we need to live with the virus. So we need to empower the public, to take responsibility to live side by side with the virus. And that's the reason why on the 7th of December, we ease the restriction in terms of interstate and inter-district travel. And although we were, Ministry of Health was not very keen to, ease the restriction, but we were hoping that the public will comply to the SOP. But when we ease the restriction, then there's a lot of activities of going back to their kampong and also local domestic tourism, etc. And then we see a spike of cases following the decision in order to ease the restriction. Next. So the evolution of Malaysian SARS-CoV lineage analysis from the beginning, we are seeing the B Wuhan ancestral. Although We anticipated this, but now it's been substantiated with genomic studies. And later, the strip tiling cluster and immigration depot clusters, mainly for C-derived strain. And then following now, we are seeing clusters from Kedah, Johor, and Sabah, and recent cluster with B-derived. And also, we managed to detect mutation. The mutation that we've seen in our country, in Kedah, for example, the Siva Ganga cluster is D614G mutation, protein spike mutation. Then we had in Sabah, protein spike mutation of A701V, and subsequently now we realize that this mutation, spike protein mutation, has replaced the Wuhan ancestral strain. Circulating about more than 100%, 100% of our current infection, they are all from the D614 strain and 70% from the A701V spike protein mutation. Next. So transition of a spike gene mutation, there's no persistent spike mutation that we see early outbreak during the strip tiling immigration depot. Then as I mentioned earlier, the D614 came around from Siva Ganga, and also we have documented the D614 from Manila, from the cluster of Tampoy, and then the A701 mainly from the Benteng and post-Benteng clusters in Sabah. Next. Now, our approach in COVID-19, and then we look into a more holistic public and private integration of services. So the first most important approach, preparation that we did in 2018 in December is the preparation to diagnose our enemy. That is a virus. So we have enhanced our laboratory capacity. And once in China, they released the genomic sequence on the 3rd of January 2019. So we primed our lab and prepared the RT-PCR, working together closely with University Malaysia hospitals, and came up with the RT-PCR testing. And we started training our staff in the lab, public sector and the private sector working together, enhance our lab capacity. So we started with 23 labs with 23 laboratories with 1,000 RT-PCR capacity a day. And we continue to step up until today. We have 68 laboratories doing RT-PCR with a capacity of 76,000 cases a day. So that was the diagnostic component of it. And then we continue to do the public health interventions. And most important is evidence-based approach. Whatever we do have some experience from previous outbreak, for example, SARS, MERS-CoV, H1N1, etc. But this is unprecedented pandemic, the first time that we have experienced, and from a different magnitude and scale. So we also have Act in place, as Act 342, and but it was actually meant for to contain a smaller scale of infection. But we have to use this Act to help us in terms of contain and the infection. So prevention and control protocols are all in place, treatment and clinical protocols, and all this experience, health technology assessment, all are based on evidence, current evidence, etc. So we have 5 strategic approach in terms of to combat this COVID-19. The first most important is border control. The international border, the interstate border, interdistrict border. So we continue to do so. Second is that to look into a health system capacity and capabilities. So how to scale up our healthcare system, integrating the public and the private sector. Third is that we look into the public health response in terms of surveillance, the community, in terms of contact tracing, active case detection, targeted approach to mass testing, and doing the cleanup and mass screening of enhanced CMCO in certain localities. All these are important public health messages. For example, avoid the 3 Cs and practice the 3 Ws. And we have the CAPP and the RRP, that is Community Empowerment Program. And the fourth strategy is basically to protect the vulnerable population. Say, for example, looking into the Aborigines, Orang Asli, or the rural area, long houses, etc. Because our fear is that if the infection spread in this community and their immune system is not as strong as those who had the immunization, etc. So this is the challenge that we have. And the fifth, if you look into communication, strategic communication, and we must be transparent, factual, and consistent. So here we engage with the public, important engagement with the public daily to explain issues and challenges and to manage the public expectation. Hopefully that we can get trust from the public, looking in our data and as well as factual in terms of interpretation, etc. Last but not least is public empowerment. So we believe that, if the responsibility is on the shoulder of Ministry of Health alone, we would not succeed in terms of to contain or even to win this war. We need the whole government and whole public, whole society approach, whereby every individual is important to contain and to help us to fight this infection. So this is a whole approach that we have for COVID-19, and we were complemented by the movement control order that is started during 18th of March 2020. We started our very tight movement control order, but at that point of time there was a lot of unknown to us in terms of the virus and whether our approach is right, and learning from other countries. So we were perhaps overdoing it a bit. For example, looking into the state of Sarawak and Perlis, there are no cases, but we still impose on them the movement control order. So now we are more targeted in terms of approach in certain districts, in certain states to contain the infection. Next. So the Malaysian preparedness and planning began since December 2019. So before we had our first infection documented on the 25th of January, so the CPRC team, the Health Ministry, ramping up our border screening over the China influenza outbreak, and also we started to have our guidelines to prepare our staff in terms of, and our facilities and how best we can integrate the public and the private sector coming together. And we believe that coming together we can make the impossible possible. And although we are living in a very challenging times, and working as a team, the unity is a key for us to break this chain of infection. And we need to strike a right balance between life and livelihood. And certainly loss of balance means loss of lives and also loss of livelihood. So our strategy is to impose on the short-term pain and the long-term gain. And this is why we do not see any reason for us to extend the MCO longer. So we just need a short MCO, 2 weeks or 4 weeks maximum, and to contain the infection, and then we back to CMCO or RMCO, but provided the public must comply to the SOP. Next. And the Ministry of Health Crisis Preparedness and Response Centers are very important centers that we have actually developed this over the years from our past experience of managing other communicable diseases. And we have a national CPRC. We started activating this CPRC on 23rd of January 2020. And we have a command control coordination center. And we also coordinate with the hospital services CPRC and the state CPRC and hospital operation room. So we do have a network in terms of how to manage this pandemic response in our country. Next. The targeted approach mass testing has been adopted since day one, or in other words, a selective mass testing. So we have 3 areas that we're looking to. First is a surveillance screening. This has been ongoing for many months. Sentinel influenza-like illness and a severe acute respiratory infection in our hospital. Healthcare worker screening periodically we are doing. And the latest was the pre-operation screening, because I think it's very important for us to screen every patient before we do the surgery. And other screenings that are in place is person under investigation screening, close contact screening, community screening, symptomatic screening, ward and hospital admission screening, pre-employment screening, workplace screening, self-screening, or even BID, brought in dead cases. We also screen them, before post-mortem is done, and arrival on high-risk area and screening has been done as well. So we also focus on the targeted group, basically the large street tiling cluster, and in certain schools, for example, Tafiz and Madrasah screening, the Ministry of Health Healthcare Worker Screening Program, and we enhance the CMCO screening. If we CMCO an area, so everyone, regardless of local or foreign, will be screened. And travelers, all cases coming back, Malaysian returnees, for example, and those coming to Malaysia will be screened at our international gate. And also, we also focus on certain cluster in markets and foreign worker screening in the red zone area, foreign worker screening under the SOCSO program, elderly care centers, plus the retention centers screening program. So these are some of our screening. To date, we have done more than 5.297 million individuals have been screened as of 9th of February 2021. Next. Our hospital preparedness for COVID-19, we have 4 phases. We started with the alert phase, that is in January 2020. Later, we went on to early containment, and now that we are in the late containment and also perhaps a mitigation phase, that's the emergency phase. So we went through one strategy to another, how best we can adapt, and then to fight this war against COVID-19 in our country. Next. And to date, that we have changed our strategy because of the increase of number of cases. We are not able to contain and to admit all cases, positive cases, category 1 and 2 in our quarantine center or even the hospital. So we have started category 1 and 2 to be isolated at home. So, we have established this COVID assessment center. All positive cases will have to be placed and assessed in this center before we decide the high-risk group and low-risk group. Those high-risk group will be placed in quarantine center, but those low-risk group, perhaps we can consider to be isolated at home, provided that they have a suitable home that they can isolate themselves well. And they need to upload our MySejahtera apps program for home monitoring. And these are for category 1 and 2. So every day we will monitor them from 9 o'clock until 12 o'clock to get all the information from them in terms of the symptom, progress, and etc. So at 12 noon, the information will be analyzed and then sent to the PKRC. And we do have also established a unified command center whereby we look into the wards as well, the beds in the ward as well as the ICU beds, integrating the private hospital, the Ministry of Health hospital, the University and Army hospital, and in terms of how best to manage, maximize utilization of our resources, and to know which hospitals or beds available and ICU beds are available. Thereby, we can actually utilize the beds and optimize it as best as we could. Next. So this is a COVID-19 assessment center, the flow. You can see it very well that how we can monitor and how we can refer a certain patient to the hospital or even a quarantine center if needed be. And most important is that, to step up our monitoring at home, for example. So the objective of this center is to identify patients who are suitable to be monitored at home, to be monitored and access patient at home using standardized tool that has been established to identify and access patient with disease progression as well as to coordinate referral from health clinics to the quarantine center or hospital. Next. Okay, now we are looking into the SEER model of COVID-19 daily observed and forecast cases from 12 September 2020 to 31st May 2021. So basically, we're trying to capture the progress of the third wave. So as of 9 of February, yesterday, the estimated RT or R0 for Malaysia is 0.91. So you can see that initially we started with the R0 of 2.2 on the 20th of September. So in the implementation of CMCO, we managed to bring it down to between 1.2 and 1.1. We were not able to bring it down further. So and during the third phase, third wave is certainly very challenging as compared to the second wave. But nonetheless, we are more prepared than the second wave because we know more about the virus and how best to manage this virus. So on the then we started the PKP or MCO on the 13th of January. So we expected 2 weeks there will be to prevent the surge of exponential surge of cases. The next 2 weeks, the fourth week is to plateauing the graph, graph as well as probably see a downward trend. So on the 31st of January, we saw a peak that is 5,298 cases. As you can see here, the forecast is much higher, the projection much higher than the R0 or RT of 1.2. So last 9 days, we continue to see the plateauing and also decreasing numbers of cases. And we hope that this trend will continue. So far today is 0.91 for the last 2 days, yesterday's and day before yesterday's. The RT is 0.91. Next. Now, so this is the trending of the R0 or RT that we have seen from the 1st of January, and then you can see that the peak was on the 31st of January, of which the RT was 1.16 with 5,298 cases, and then we see some good progress of declining R0 RT status to 0.91. Still not good enough. Our target is to achieve at least 0.6 or 0.5. Then we can rest assured that every 1,000 cases, the next cycle we will have 500 cases, and the next cycle, 7 days, we will have probably 250 cases and so forth. Next. So this is the daily cases, 7 days moving average in Malaysia. So you can see that the projection, the forecast of RT or R0 1.2 and 1.1. And the implementation of the 4-week MCO followed by CMCO from 13 January to 9 February, and then we have extended now because of the Chinese New Year. It's going to be certainly a make or break situation. Because of that, we have extended to 18th of February after the Chinese New Year. So we hope that we can bring down the RT from 1.1 to at least 0.6. So we can see the peak, highest average 7-day moving average was on the 31st of January, and now we are seeing the trend of declining trend. So hopefully that this will continue. Although you can look into the red zone, although our projection is cases are much less, peak of about 2,700. But in reality, we are seeing 5,000 cases, but during the same period of time. So we hope that the numbers are high, but the projection, same period of time, is responding to our projection and trajectory. So we hope that next couple of weeks we can actually bring down the whole cases towards a downward trend. Next. And the cases among Malaysian citizens, initially when we started in October, non-citizen foreign workers, much higher in terms if compared to the local. 65% foreign workers, and then local about 35%. But today things have changed. Look into the citizens, much higher, about 70%, and the non-citizen foreign workers about 30%. Next. And the sporadic cases also have increased. Initially, mainly we are seeing cluster cases during the second wave, but here during the third wave, cluster cases are less. 70% of the cases we see sporadic, which means that the virus is already in our community. Whether we like it or not, we have to live with the virus and to take precaution, public health measures in terms of to prevent being infected. Next. So, and our screening surveillance positive rate, but weekly, you can see that there's increased number of ID cases, SARI cases, pre-operative cases, and etc. So, this is certainly a very challenging period of time because the virus is already in our community. We are not in the attacking mode, but we are in the defensive mode now. So the only key to success is to comply and have a high self-discipline in terms of comply to all our SOPs. Next. So increasing number of patients also have been admitted to our ICU and hospital. You can see in our ICU, for example, the cases has increased from September onwards, and we have more patients being ventilated. And also non-ventilated patient placed in ICU. Next. So looking into our mortality until 9th of February, 87% of the mortality that we had are Malaysians, and then 38% comes from Sabah, and 65% mainly male, and 84% those who have succumbed aged more than 50 years. And 87% have at least one comorbidities, diabetes or hypertension, and we have 22%, 202 cases been brought in death, BID to our hospital. 87%, 615 cases are presented at stage 4 and 5. Next. So we look into the census in 2001, total of 372 patients died in our hospital, and total of 66 are brought in death. And you can look into the numbers. Total death in 2020 is 471 cases, and to date we are coming to second month, that is February. We already have 438 fatalities. So this is a concern to us, and perhaps we are looking into a more severe form of infection in the community, and basically we need to protect the vulnerable population. Next. So the COVID-19 dichotomy is balancing the economy versus health. So we are in a shared struggle to protect both life and livelihood. This is not easy. In every meeting that we have, we need to strike this balance, and it's not easy to strike the right balance between health and economy, between life and livelihood. And I always say loss of balance means loss of life and loss of livelihood. Next. So finding the optimum balance between health control, COVID cases, and economic livelihood, what is possible? So if we were to look into the lockdown on the extreme right, then you can see the impact on economic outcomes. But certainly the lockdown for 2 weeks and 4 weeks, we can see the impact in a controlled environment, less cases. On the other hand, if we follow the herd immunity approach, or even manage our economy well, but if the cases goes up, the economy will goes down. Again, the impact will cost us in terms of life and livelihood. So if we were to strike the right balance in terms of economy and health, then it will take the duration, the time. So unless we do it in terms using the MCO, tighter, stringent, tougher measures put in place, then our economy will recover fast. So our principle is a short-term pain and a long-term gain in terms of economic growth, rather than moving towards uncontrolled cases and spread of COVID-19 in the community, and the economy goes down as well. So that is the worst scenario on your left. Next. So the National COVID Immunization Program, so that's how we have done what we need to do best, that is actually using the NCO for 4 weeks, and then after 18 probably will revert back to a CMCO, that, and hopefully we'll see a downward trend as shown earlier. And our second strategy depends on the immunization program. So hopefully by the end of this month, we will get our vaccine, and we'll start with phase 1 for all frontliners, phase 2 about 9.3 million for those vulnerable population, phase 3 is for adults 18 and above, phase 4 is mainly that we look into vulnerable population that we need to vaccinate. Next. So that's about all from me, and I hope that this is just a summarize. This presentation summarized our journey over the more than 1 year, and certainly this is a marathon for all of us. But more importantly, we have to come together, working as a team, see how best we can move forward. And I'm sure all our frontliners having experienced fatigue mentally and physically. But the war is not over yet. The virus is still very active and mutating. So the challenges ahead, we need to re-strategize, hoping that our public health measures as well as the vaccination will work in time. And we hope that we can contain and even end and win this war in a short period of time, probably end of this year or even next year. And certainly this is a long journey for all of us. We hope to see some light at the end of the tunnel. So this is coming together and survival of the fittest, working together to make a big difference in our healthcare in our country. Thank you very much.
That was the recorded speech of Tan Sri Dr. Nur Hisham, done on the 9th of February. We can all appreciate how busy Tan Sri is, so we are very grateful that he had taken the time to share with us the nation's approach in flattening the curve and raising the bar, engaging the public, managing information, public empowerment, and the whole of government and whole of society approach. It is important for the public to comply with restrictions in order for us to attain the short and long-term targets. As he said, the war is not over yet, despite the vaccines arriving soon. So I hope we, the public, will take heed of Tan Sri Nur Hisham's plea to remain compliant and persevere and not fall through to pandemic fatigue. As of yesterday, our R0 is 0.9. The third speaker for today is Dr. Ravindran Tayan. He is currently the head of Virology Unit, Infectious Diseases Research Center and Institute of Medical Research in Malaysia. He is a molecular virologist by training with research interest in viral diseases of public health importance, such as dengue, influenza, Zika, chikungunya, polio, and COVID-19, among others. He has been with Virology Unit IMR since 1992 and has been involved in viral outbreak investigations, including COVID-19, polio virus and measles in 2019, rabies in 2018, Zika in 2016, Ebola, MERS-CoV, and avian influenza in 2014, and pandemic influenza H1N1 in 2009. He is a member of several expert panels, including IMR, MOSTI, CREST R&D grant application, as well as Virology Expert Panel for Ministry of Health Malaysia. He is also the director of WHO National Influenza Center, as well as coordinator for the WHO National Polio Laboratory. Dr. Ravindran will enlighten us on the advances in laboratory services with regards to COVID-19 in his talk entitled Updates on Laboratory Diagnostics of COVID-19. Let's welcome Dr. Ravindran to deliver his talk.
Thank you so much, Dr. Rosman. A very good afternoon to Lieutenant General Dato' Pahlawan Dr. Muhammad Amin, Tan Sri Dato' Sri Dr. Hisham, distinguished speakers, as well as respectable attendees of this webinar. First of all, I would like to thank the organizing committee for inviting me to give an insight into laboratory testing. Please allow me to share my slides. So this is the outline of my presentation. I'll be talking about the laboratory testing for COVID-19, followed by a bit of diagnostic kinetics of COVID-19. That will tell you what should we look for at different phases of the disease, best testing method at different phases, the interpretation, as well as the different testing platforms. So this is just giving an overall the importance of laboratory testing of COVID-19 because it's very important to confirm the case, isolate the case, as well as we manage the case. And as we know, the gold standard for COVID-19 testing is real-time RT-PCR. This is based on CDC or WHO or Ministry of Health guideline. Having said that, there are three main components in testing. First of all, we need to ensure we collect the sample at the right time and using the right technique. And secondly is to ensure the transportation of sample. We should maintain the cold chain as well as the duration of transport so that the quality of sample is maintained at all times. And then finally, we have to test the sample using the most suitable method and done appropriately. So this is very important for us to give very good reliability. So this gives you a diagnostic kinetics of the SARS-CoV. There are basically three main phases. The incubation period is when you're exposed to the virus at that point of time where you don't have any symptom, and followed by the acute phase where you start having symptoms, and then the third phase is the recovery phase. So there are days where the test is so this will tell you what tests should you use at the different stages. So basically in acute phase where you have symptoms, you should look for the virus, which includes RT-PCR or RTK antigen as well as viral isolation. Whereas in recovery phase is where your body will mount an immune response, and so you have to look for markers that will tell you that you're recovery. That includes IgM and IgG as well. So this is basically, in a nutshell, the type of test at different phases of disease. Acute phase usually, we know that it's first early infection, usually first week of symptom in most cases, and that's when you are highly infectious. And basically, early infection is where you are highly infectious because you will be shedding the virus. So what kind of test can you use to detect the virus? This includes PCR, which is the gold standard. I will elaborate further, as well as RTK antigen. We will detect a part of the virus, which is the nucleocapsid, as well as viral isolation, which usually, because SARS-CoV-2 is this group 3 organism, so which means only selected labs can do isolation because you have to do in a biosafety level 3 facility. And of course, we do also full genome sequencing. Why is it important is because we do know there are some variant of concern, the mutation occurring at the spike protein, which will have impact to the vaccine as well as diagnostics. And also the second phase of the disease is the recovery phase. Usually, in most cases, is usually a second week of symptom and beyond. And then what tests can you use during recovery phase? Will be looking at tests that will detect the immune response. And basically the two important markers here, the IgM as well as the IgG. IgM usually will last about 3 months, whereas IgG basically can last longer. What kind of platform can you use is basically the two types of platform. You can use an RTK antibody, which is a rapid test, as well as ELISA platform, which is robust and you can do more testing. This picture, what I'm trying to tell you in this slide is basically the reliability of tests. Basically, what we are trying to say is the prevalence is very important. Based on the prevalence, it will give you what we call as positive predictive value. The higher prevalence, the test becomes more value, giving you that whatever result that comes out, it gives you better predictive value. So for example, if you look at test A and test B, if you look at the right side of it, so in a population of 1 million, if the prevalence is about 1%, basically I will put here, so in a population of 1 million, if the prevalence is 1%, meaning that only 10,000 people are infected. But if you use a test that has got sensitivity of 71%, it can only detect 7,100%, and which gives you a predictive positive value of 41.76% really. And test B, when the sensitivity is even lower, it gives you a positive predictive value of 33.56. Whereas if you are looking at the high disease prevalence, say here we are putting 20% of the people have been infected. So in that kind of scenario, so you use the same test, and just now the same test which got sensitivity of 71%. But however, when the high prevalence setting, it managed to pick up 142,000, which means it gives you a PPV of about 94%, which is very good. The higher PPV will give you more reliability. So basically what the slide shows that, and you have to use prevalence as well as tests to know whether it's reliable or not. So going back to the testing algorithm, remember when I mentioned about acute phase of infection, we're looking at the virus, and we're looking at detection of virus. The gold standard is actually real-time RT-PCR till now. And if you look at WHO's or CDC's or even Ministry of Health guideline, we have to have at least 2 target, gene target, based on this following, the envelope, the RDRP or the nucleic capsid, ORF1AB or M, and unfortunately or fortunately, it takes about 2 to 6 hours to complete. That's a bit lengthy. So the test principle, what does it? Why is it used? Why do we say it's gold standard? Because what is the test mechanism is because it's used some kind of reagent called primers and probe. And if you remember when it's small, you use LIGO to LIGO where you use to fit. So basically the same system it works here. So if your target is your SARS-CoV, so if you design primers and probe against SARS-CoV-2, it will be able to stick to able to bind to the target. That's why we say it's the fitting system like Lego. And this gives you high reliability, because if you are trying to use another, say you design primers probe against influenza, and we use these primers to detect COVID, it won't detect. So this is the reason why this is a very targeted, it detects genetically compatible target. That's the reason why the authorities using real-time PCR as the gold standard. So having said that, how do we interpret the result? To say a PCR positive must have the following. Basically, the most important point here is CT value. I think that will tell you about the positivity. So it also depends on what kind of kits many of the labs are using. Basically, usually most of the CT values threshold, meaning positivity threshold is where the CT value is below certain threshold, it will be considered as positive. So over here, if you look at this diagram here, so when you say real-time PCR, what is the mechanism happening is it's a mechanism of detecting some signal from the reaction. So this signal will be monitored, and the amount of signal will be monitored according to the number of cycle. The higher cycle, that means the chances of producing more signal will be higher. And again, it depends on what is the viral load in the initial stage. So comparatively, if you look at this graph, there are 1, 2, 3, 4, 5, 6, 7% or 8% here. So the graph on the right shows that the person is the threshold, it passes the threshold earlier at cycle number 14, meaning that CT14, it passes, saying that this person is positive at CT value 14. As you compare at the last end of this graph, the yellow line, this person becomes positive at 38. So what does it say is that you need more cycles to achieve the positivity. So that again goes back to how much viral load in the initial stage of the infection. So if a person who has got high viral load will quickly become positive earlier in this stage, which means this person is still highly infective as compared to a person who is in the late stage of the recovery stage, where the CT value is above 35, it may not have infectivity. So that again goes back to the next slide. There is a correlation between CT values and infectivity. So we know from this, just now when I explained, the lower CT value is translated into higher viral load, which is also higher infectivity, and higher CT value translate into lower viral load, which is lower infectivity. Having said that, you have to remember when you interpret this, please remember to use the kit insert because there are variation between kits to kits. Some kits will have 35 or 30 CT values and some up to 40. So you have to interpret accordingly. So what is considered as CT value with infectivity? So this is very important because I think we are using to manage patients in the hospital. So IMR have conducted an in vitro experiment with infectious disease doctors from Hospital Sungai Buloh, where we look at a range of CT values, clinical samples collected from range of CT values, meaning from 20 to 30 to 35 to 40. We take all these ranges of CT value and we try to infect into in vitro. That means we try to infect cells that can support the growth of this virus. And we found that CT value below 32, meaning that 30, 25, 20, 15, there is probability of successful viral isolation. What does it mean? Meaning that this is still in infectivity stage. And as a comparison, when you look at CT value above 32, 32 to 35 to 38 to 40, there were no successful viral isolation. There's no growth in cell line, indicating that they're not infectious. So having said that, we have to also be careful in interpreting, because remember, during the incubation early period of exposure, the incubation period, usually the CT value is quite high because there's not enough virus to manifest. So that's the reason why you have to take into account, when you're interpreting the CT values, you must take into account the incubation period. It's important to have clinical data as well as epi-link. So this is very important in the lab when you interpret these results, as well as the physician managing the patient. So even though PCR is gold standard, there are several limitations. Basically, the important limitations are dependent on the timing of sample collection. We know that best collection is during the peak viral shedding, which is first 5 days of onset of symptom. But again, the way we collect, because right now we know nasopharyngeal swab in combination with oropharyngeal swab are the samples that are recognized, even though I have a slide saying about deep throat saliva, which I'll come to that later. So the way we collect is important, and also it depends on a person, the timing of sample. Maybe today the virus load is quite high, and then tomorrow it will be low. So basically, it's also the way the body responds to the infection. And also it depends on cold chain, the sample collection, because we're using what do you call that, as the we are using PCR, which is a molecular technique, and that is very important because dealing with genomic material, the sample must be sent in cold, and that is to ensure its quality is ensured during the sample transportation. So if it's further from the testing lab, let's say for example it's in the rural area, this must be very important. Basically because it will, because SARS-CoV-2 is an RNA virus, and there's lots of enzyme in our body which can actually chew the RNA, and so by the time it comes to the lab, we may not detect. So it's very important cold chain is maintained. And the third most important factor will be the competency of the person testing. Properly done, I say it's properly done. So for this, we usually have something called blinded sample that we give to the person and to the team, so that we know that competency is always maintained. Because of the above, it's always important to interpret PCR result with the following, because it's very important. Let's say if you take the sample and it's detected, it's not detected, it's negative, then but there are clinical presentation, there are symptoms, there are supporting investigation, the X-ray changes, other markers, there's epi-link, you have to use the interpretation and probably request for a second sample. And this is very important you interpret this result. Okay, also I think in interest of what's happening right now, we know a lot of mutations occurring in the spike protein at least, and because of that, the possibility of false negative occurring with PCR. So what do we do that to overcome this? We know SARS-CoV, because it's an RNA virus, mutate all the time, like all viruses, resulting in genetic variation in the population, like what we are seeing, the B117, the UK variant of concern. So it's very important to monitor where is it the mutation occurring. And we recently WHO did release a caution saying that if a lab is using S gene to detect use S gene as a target for PCR, be careful in interpretation. And so that's the reason why it's always very important to rely multiple target of the genome. So please do not use just one or two target. We have multiple target of the genome, so that you are not very much impacted by the genetic variation of the SARS-CoV genome. Okay, so basically, this is a recommendation. We must always be monitoring the genetic variation of SARS-CoV regularly. Be aware that labs should use multiple genetic targets to determine the final result, and consider negative results in combination with clinical observation, patient history, epidemiology information, and do consider repeat testing with different tests with different genetic targets if COVID is still suspected but receiving a negative. These are these recommendations. So having said that, we also must prepare, because we know like many countries are also already rolling out vaccine, and Malaysia is soon, I think in weeks time, we will be rolling out our vaccine. And having said that, we even though the vaccine will be rolled out, but testing, tracking, tracing, isolate strategy will still be continued to be essential, because we know, it will take a lengthy period for the entire population to be immunized. And having said that, only TTI can prevent future rebounds of infection following lockdowns. And we know basically it's very important to look at duration of neutralizing antibody. So post-vaccination, because we know what is protecting a person is usually the neutralizing antibody, and we need to know how much antibody is considered as neutralizing, considered as a protective antibody, and how long the antibody lasts. So basically, this is ongoing study, and while having that, you still have to detect. Use tests that can detect the virus. Basically, you can use RT-PCR as well as RTK antigen. And at the same time, it'll be good to include tests now, because since after vaccine rollout, at least after a few months, you start looking at quantifying neutralizing antibody among the recipients of COVID vaccine, because this will tell you the overall protectiveness of the vaccine. So I just talked about real-time PCR as well as that, but now I'm going to the other important test that can detect the virus or protein of the virus, which is antigen testing. Malaysia started, we are among the first countries in the world. We started antigen testing way back in May 2020, because at that point of time, we were looking at how best we can use to complement PCR. Even though RTK antigen is still considered, if you look at WHO, even CDC guideline, it is considered a screening tool, which means if you have RTK antigen detected, it's only a probable case. But having said that, we also look into what we call as concordance study. Concordance meaning that in areas where there is little molecular testing ability because of infrastructure, because of the not availability of PCR, then we also can use RTK antigen, but with a correlation study, meaning that you do a correlation between the same sample, you collect sample and look at RTK antigen and PCR. If the concordance is above certain value, in our experience, we find that in Sabah, especially in Sabah, in October, we did a concordance study about 85% and very good concordance. And having said that, because of that, we had used that to diagnose, which means we don't need RTK antigen that were positive to be retested by PCR. We use that, and then quickly we can able to isolate person who is positive. And having said that, this is only possible, you have to look at the prevalence on a rolling 7 days. You have to make sure on a 7 days period, you have to have the prevalence maintained at above 10%, so that you can use RTK antigen as a diagnostic assay. It has been useful in areas where there's no molecular lab, logistic issue in certain parts of Sabah and Sarawak. And when TAT is longer, more than 3 to 5 days, because basically very important for us to isolate the person. So if TAT is very long, I think that's the reason why we quickly devise the use of RTK antigen, having done the concordance study. Looking at what kind of logistic that you need is basically, there are two protocols Ministry of Health shared. One is using biosafety cabinet. The reason being because the process of doing the test, there is some kind of potential droplet. That's the reason why if you have a lab with a limited space facility, limited space, then you should have a biosafety cabinet. But if you don't have a biosafety cabinet, you should have a dedicated area, a bigger space in the lab with good ventilation, or you can even do outside. Basically, because you do mitigation for droplet quotient where it is about almost 2 meters, so you can have the area where the person who is doing the test is fully wearing PPE, but there is an area of space. Make sure that. So the third test that I will be talking about is the use of RTK antibody. Having said that, serology tests cannot be used to indicate infection. This only can be used to indicate exposure. So this is an easy test that you can pick, finger prick and measure. It's a 20 minutes test, and we're using as a PUI or PUS on the day 7 to show possible exposure. And the other method that is using a ELISA platform, where it can be because basically when you look at antibody, this is evidence of exposure. So in the light of vaccine rollout, we have to look at what mechanism, because using a RTK antibody, because it's not really robust, you have to do many, and so the platform that we should look for is more robust and has higher throughput. Very important that we are getting ready for this. And also very important to look at both the seroprevalence of this virus in our population, as well as duration of neutralizing antibody, where we do the longitudinal study, where we look at people who have been exposed, who were infected with COVID quite some time, and we do a serial collection of sample and look at how long this neutralizing antibody lasts. And this is also very useful to as an indicator for vaccine efficacy when this vaccine comes out. The other strategy that I would like to share is pooling of clinical samples for real-time RT-PCR. We have tested this pooling, meaning that basically you can pull clinical samples together and you test them, and that is a very clear algorithm which I'll share shortly. IMR has evaluated pooling strategy of 2 samples as well as 5 samples. Is basically pooling CDC's criteria as well as Vidral Australia's criteria. Way back in April 2020, and that was last year. Among the factors to consider is suitable in low prevalence setting on a rolling 7 days, and also very important, you follow strict SOP to avoid risk of false negative. So this is the 2 pooling and 5 pooling that algorithm. 2 pooling meaning you take 2 samples. Basically, in an RNA extraction, you need 200 microliter samples. So you need to pool, you take 100 of each and you pull together and you do extraction. If the sample is negative, both sample you can report as negative. But if the pool sample is positive, you have to go individually and test. So this is 2 pooling. Likewise, 5 pooling is 5 samples pulled together and at the same procedure. The thing is that in the event of important, the next slide I will show you, where is it applicable? Because in our own experience, during the second wave, we did this pooling in second wave when we have samples coming from green and yellow zones where the prevalence is less than 5%, very successful. We didn't have to repeat, because when you have positive pooling, you have to repeat. When you repeat, you're going to add another 6 hours of your turnaround time. So basically, you're going to expand further the results. So it's very important you have to look at the prevalence, because if possible, we don't want to repeat. So for that kind of situation, you must have low prevalence setting where when you take samples from green and yellow zone, most of the time the positivity rate is less. So most of the time when you pull, it becomes negative and we can report as negative. But in our experience, when in the third wave, when we have samples, especially from Sabah, when you start pulling, we have to repeat many of the samples. So it increases the turnaround time. And when you pull and you repeat, it's also waste of reagents. So that's a very important, when you want to pull, US pooling strategy is very important. You evaluate this situation and looking at prevalence. And this is very important right now. The new, I think, new findings that basically it's not really new, but we have been doing this use of deep throat saliva as another sample for testing. We have evaluated both samples. First sample that we evaluated was early morning saliva, and then second sample is deep throat saliva as another sample for COVID testing using RT-PCR platform. And their results currently indicate that those samples were equally as good as NPS for testing of COVID-19. And we have published these 2 papers. At least 2 papers have been published. So what is the important finding from here is because then it's enabled deep throat saliva instead of NPS, and it's another sample. And because this is self-collected, you can just train the person to be self-collecting, and you supervise. And because of that, there's reduced use of PPE and can be done in many sample collection. And more importantly, right now, IMR is also evaluating the use of RTK antigen as another method to use the deep throat saliva. This will really game changer, because then you can do the testing more frequently, and basically in the field testing. And very important, and this slide shows you about how do we maintain quality assurance, because as a leading lab, as a reference laboratory for SARS-CoV, to ensure that the labs that are testing are meeting certain proficiency testing. So we did recently, or late last year, IMR sent out what we call as propagation testing. What does it mean? Is actually is consisted of samples that are predetermined positive and negative samples that are blinded from the laboratories. That means when the laboratory gets the sample, they will never know which one is positive and which one negative, and also be mixed with all the laboratories, so they will not share. They will not know who's getting what. And this panel is distributed last year only once, but this year we're planning twice. It's very important to monitor performance of laboratories performing COVID testing, because I think it's important that when you do that, the result that comes out from the lab is very highly reliable. In addition to that, there are also external PT or QAP program, which is provided by WHO or RCPA, which the laboratories can also participate. And it's very important to having say that one area we want is testing as much as possible, where we engage the private labs and all. But at the same time, to ensure quality, we have to ensure that the labs participate in PT panel. I think that's about that. My slides. Thank you so much for your attention.
Thank you, Dr. Ravi. I was enjoying that, and I know time is very limited, but you were racing through at the end, so we're sorry about that. Now there are some questions, few questions actually, but we don't have time for many. I just read you the first, if I may. There have been cases of previously positive COVID-19 patients already discharged but readmitted with respiratory illness. We know that COVID patients may be PCR positive weeks after discharge. Some remain with low CT value. The question is there any study in Malaysia on infectivity of these patients who generally are regarded as non-infectious after 10 to 14 days?
So basically, is it referring to reinfection or probably after discharge? So
there's a different question on that as well.
Okay, right. So in early stage, I think during early stage where we were using PCR multiple times as a discharge criteria as well, I remember the samples that were sent to us that from patients who were actually discharged, but after 2 weeks they became positive, and they were. But when we did PCR, it is 38, 39. So having said that, because there are a lot of papers out there, PCR, because it can detect remnant, it can detect remnants of the virus, because when you swab at the nasopharyngeal, sometimes the remnants still there. So that's and the samples were put into culture. That's a no growth at all. So to know whether it's infective or not, we put into culture. There was no growth at all. So what it shows that unfortunately PCR, because it's highly sensitive method, it can detect even remnant of the virus. So at that point of time, we know some patients were admitted for about 2 to 3 months. The virus, because at that point of time we still waited for the discharge criteria of PCR negative. So it is still there, but it's not. It's not a viable virus, because we put it into culture, it's not growing. So it's just a remnant of the virus.
So currently, is it normal practice for those patients after discharge with COVID-19, they come in with respiratory illness? Do we do the PCR again?
So there were a good question. There were some of these who were referred to us. Basically, there are people who came back, but we are very important that we have to remember because influenza can be another infection, respiratory, because that is another factor that you have to look into. But having said that, if the concern is reinfection, there's certain guideline for reinfection to say that a person reinfected with another virus, another SARS-CoV, where we have to do full genome sequencing of the virus to know. Basically, from the first sample and second sample, we do full genome sequencing to know it is different virus altogether. So that's when we can prove the reinfection. Because this person who are coming back after 2-3 weeks, most probably they may have some symptom, but it may not be SARS-CoV. It could be something else. So they have to rule out other respiratory tract virus as well.
Okay, on that score, we do genome sequencing in IMR, do we?
Yeah, currently IMR is one of the leading labs that are doing. In addition to IMR, I think the university labs are also contributing a lot of full genome sequencing.
Okay, final short question. RTK positive, PCR negative. Patient is asymptomatic. Any explanation to that?
Okay, RTK antigen positive and PCR is negative. Patient is symptomatic, right? Your question. So basically, when you look at RTK antigen, it's a quick test. So the sensitivity of RTK antigen is not as good as PCR. So when you have PCR negative, so we
positive.
think positive.
It's
Sorry,
PCR is negative,
right?
sorry.
PCR negative. So
Yeah.
when you have PCR negative, PCR is more reliable than RTK antigen. So the thing is that why do we have RTK antigen positive? Is there are two things here. Because looking back at the specificity that we did, is usually when we do the specificity, we look at other respiratory virus, including the common cold coronavirus, as well as influenza and adeno. It did not pick up any other common cold coronavirus. Didn't pick up any respiratory virus. But having said that, RTK antigen is very important how you interpret, because if the time period is 15 minutes, we read at 15 minutes. You should not read beyond 15 minutes. Say a person forgets to read at 15 minutes and reads at half an hour later or 1 hour later, most probably there will be a faint line or something like that because of the length. And that is going to give you a false positive. So it's very important you stick to that duration of time. That's the reason why RTK antigen, because of that, is not high throughput because of the time. So you have to do and be very careful of interpretation. Whereas PCR is more robust, and because the thing with PCR is because a small copy number virus will detect. So it's very important to relate to infectiousness, because PCR, the sensitivity can detect up to 20 copy number. But are they infectious or not? That's a very important question. So these are things how you interpret. Basically, you have to use clinical presentation, epic link, a lot of factors for you to come up to the final interpretation.
All right. Thank you, Dr. Ravi. Sorry, because of the limited time, we have to proceed. Thank you so much.
Thank you so much. Thank you so much. Sorry, I overtook the time too.
Thank you. Okay. So the COVID-19 vaccine is a hotly debated topic around the world today. Even so, today, nearly 195 million shots of the vaccine have already been given, with Israel as a nation having given nearly 90% of the population. Shedding some light on the COVID-19 vaccine for us today is Professor Dr. Organised. Dr. Gurel is an innovation leader, author, keynote speaker, academic, and executive manager. He has over 35 years of experience spanning multiple sectors, including biomedical science, clinical medicine, strategy, consulting, marketing, business development, executive management, and R&D management. With his domain expertise in medical devices, digital healthcare, healthcare IT, molecular biophysics, and medical imaging. He has authored 14 peer-reviewed scholarly papers, presented at conference proceedings, given keynote addresses and other speeches at scientific and business conferences and seminars worldwide, and co-invented 10 patent applications. He holds a few academic appointments and has had other previous executive roles in international companies in Korea, Singapore, and United States. Currently, he's a visiting professor at the Seoul-Bridge International School of Business and visiting teaching professor at Daegu Gyeongbok Institute of Science and Technology. He also holds executive and strategic positions in innovative companies in USA and Canada. He is also advisor for Crest Malaysia Digital Health Cluster. With his extensive experience in R&D, molecular biophysics, and biomedical science, he will unravel the issues and challenges of the COVID-19 vaccine. His talk is entitled COVID-19 Vaccines, Issues, Challenges, and Expectations. Please welcome Prof. Dr. Organised.
Thank you very much. It's a pleasure to be participating in the Malaysian Military Medicine Conference. And I wanted to thank the organizers and the Defense Services Agency and affiliated organizations for hosting this wonderful program. I've had a chance to listen to the previous presentations and really enjoyed some of the insights presented there. So my talk will be about vaccines, but actually frame this more broadly because as Brigadier General Dr. Rosman bin Rahman mentioned, the new opportunities and new learnings that come out of this crisis. And I'd like to present my thoughts on that. As Lieutenant General Dr. Dato Amin mentioned about being at war, of course, many details related to that. And I wanted to talk about not just the battle, I view the vaccine as part of the battle, but a bigger war that's even beyond just COVID that has been exposed by this crisis. Dr. Nur Hisham, who is a fellow advisor and engaged with Crest Malaysia Digital Health Cluster. I've had the pleasure to work with him, and it's a great honor to share the stage with him. He mentioned about vaccines and quote unquote other measures. So I think that's very important. So I will frame this also more broadly. And finally, Dr. Ravindran, his very nice presentation about testing, talked about viral load being very important. And one of the key issues with vaccines will be about disease severity or preventing disease severity, as well as preventing transmission. Those are still open issues, and they will affect the epidemiology and impact of this disease. And I'll touch upon some of those. So I thought this was, a good opportunity to further develop some of these very important insights that were shared in this conference before. So I will share my screen now. Okay, Bismillahirrahmanirrahim. COVID-19 vaccine issues, development, and expectations. I start out with a quote from Sir Francis Bacon, one of the founders of scientific method. Knowledge is power, but we unfortunately don't have complete knowledge. So I still think some knowledge is power, and that's going to be a theme of this presentation today. In other words, we don't know, as I mentioned, the vaccine effect on severity versus transmissibility. And there's so many open issues related to the testing as well, for example, with the mutation. So we don't have complete knowledge, and certainly we may never have complete knowledge, but we have to work with incomplete knowledge. But many of you being doctors, of course, are familiar with this paradigm, making patient decisions and sometimes life and death decisions in the face of incomplete knowledge. So with that caveat, let's begin. So I'll be talking about four major areas: the virus enemy in terms of an overall framework, fighting the battle that we are in now, and where do the vaccine strategies fit into that, and then more broadly, winning the war. In other words, I'm going to present a very controversial thought in this presentation, that if we defeat this virus, we may have won the battle against the virus, but I think we will have lost a wider war. And so I'd like to position our thinking towards the wider war, as it were, and not just fighting this virus. So in terms of the virus enemy, what is a virus? As all of you know, it is genetic material contained within an organic particle that invades living cells and uses the host's and the metabolic machinery to produce new virus particles. So all of this is very clear, but it raises the important question, are viruses alive? And so if we classify viruses based on their outside versus their inside, the outside surface and the inside genetic, the outside surface defines the environmental stability, and that will have important implications for infection control, as well as, of course, the tissue specificity. And of course, there are two varieties of viruses, enveloped and non-enveloped. And then in terms of the inside, the genetic stability determines the genetic stability, the mutability, which we'll talk about, and also the proviral potential in the case of DNA viruses. So we have either DNA or RNA viruses. So all viruses fit into these categories. And as you can see, coronaviruses are in the enveloped RNA category. Now, why is this important? Because as many of you are doctors, you well know this, but I think in terms of public health, we have had, of course, experiences with eradicating diseases, smallpox being most notable of them, polio nearly so, or effectively so, and others. But they have unique characteristics. For example, smallpox is a DNA virus and it doesn't mutate so often. And so I think that a more, how should I say, nuanced understanding of viruses instead of just evil things out there in terms of the general public, I think is very important for our patients and for the general public as a whole. So the fact that these are envelope viruses and RNA viruses have important implications for vaccines, for infection control, and so forth. So if we talk more specifically about the SARS-CoV-2 virus, it has three parts, clearly, from the inside to the outside: the nucleic acid, which is RNA, as I pointed out, the lipid membrane, and the spike protein. And the nucleic acid, being RNA as opposed to DNA, has a very high mutability with implications for immunity and vaccines, which Dr. Nur Hisham pointed out, as well as Dr. Ravindran. And I will expand further on that. And it's used, of course, for testing the reverse transcriptase PCR test, the rapid testing PCR test. And then you have the envelope virus, which has a lipid envelope, which essentially determines the environmental viability or vulnerability, depending on your perspective. So soap and alcohol clearly disrupt this membrane. And finally, the spike protein, which determines the target. It's blocked by antibodies and used in the testing that we'll also review very briefly here. So the big question is, are viruses alive? And no, and therefore there are only two ways to get rid of the virus. One is either to physically destroy it, or second is to clear it by the immune system. And obviously antibiotics cannot kill it. One cannot kill something that is not alive. And so clearance by the immune system is going to be a very fundamental biological strategy. And obviously vaccines play into that. Now, in terms of setting up a framework, Dr. Nur Hisham explained some of these concepts very well, but I wanted to outline a two-dimensional framework, if you will, about viruses in general, with on the vertical axis, the fatality rate, or case fatality rate, and on the horizontal axis, the transmissibility as numerically described by the R0 or RT over time. Now, in general, and this has been very interesting as it's been playing out, there's an inverse relationship between transmissibility and fatality. In other words, more transmissible, such as measles, are typically less fatal, and less transmissible are typically more fatal, such as MERS, Ebola, and bird flu, and so forth. And the difficulty, of course, with the new coronavirus, SARS-CoV-2, is it's in this middle space. It's kind of the perfect pathogen, which has a fair bit of transmissibility, quite transmissible, and some of the new mutants are becoming more transmissible, and not insignificant fatality rate, of course, as we've all noted. Now, it's interesting about the evolution of viruses, and in fact, the evolution in general of pathogens, is they typically, over time, will evolve to be less fatal and more transmissible. Because that's basically following the evolutionary paradigm of spreading its genetic material more widely. So generally, we're going to move down in this curve over time. There can be conditions, public health conditions, and this is extremely important to understand, where we could move up the curve and we can get more transmissible, more fatal versions, and so forth. So for example, we've talked about or heard about some variants that have become more transmissible, roughly speaking, going down this curve. And in some ways, ironically, that should be viewed as good news. Why do I say that? The virus is trying to be more transmissible because it's trying to accommodate the fact that it can't, under various social isolation or social distancing measures, cannot be transmitted so easily. So this mutation, aside from the intrinsic mutability of the virus, going towards more transmissible variants is suggesting that we are doing on the right track, as it were. Obviously, there's another factor in terms of trying to eliminate the virus so we don't get those mutations, but that's something I will talk about later. So this is a very important curve, and I'll talk about these two factors in turn. So first, I'll talk about the fatality rate, which I've colored in red here. And so as we know, the virus attacks type 2 pneumocytes in the lung, and specifically as distinct from the type 1 pneumocytes, which are 95% of the lung tissue, and influenza attacks those. It attacks those type 2 pneumocytes that are very critical for surfactant and gas exchange and so forth. And hence we have the hypoxia and respiratory distress by virtue of the ACE2 protein on their surface. Now, another very important concept, which will also relate to vaccines, is the concept of lower versus upper respiratory tract infection. So more upper respiratory tract infections are typically the common cold coronavirus. And about a third of the common cold, which is not that dangerous, which is why it's called a common cold, are in the upper respiratory tract and by coronavirus. And they tend to have high transmissibility and low fatality, infecting the nose, mouth, and trachea. On the other hand, more lower respiratory, such as SARS and MERS, have low transmissibility, high fatality, again, following a bit that paradigm, and SARS-CoV-2 appears to be both, and this has important implications. The good news is because of this replication in the throat, a simple throat swab may be sufficient, maybe not necessarily the nasal swab, but it also has the bad news is that it spreads obviously through talking, and it's become fairly clear that it's airborne. So these are respiratory illnesses, and influenza is largely a respiratory infection. It never really has a blood-borne phase. Now, of course, people die of influenza. There's a cytokine storm, and you can have massive pneumonia and damage, in some ways more damage than in COVID, but you get a secondary pneumonia based on that. And so you can have a systemic extension and generalization of influenza, but typically you're not really infecting other cells. On the other hand, COVID, by virtue of binding to the angiotensin converting enzyme 2, which is involved not just in blood pressure, but also inflammatory processes, is also on other cells in the body. And that's, of course, with the spike protein, and the pathology is both cellular in terms of killing those cells, as well as directly and by the immune system, and also molecularly by reducing the ACE2 levels, which affect both the respiratory aspect by virtue of the cells, and by virtue of ACE2, some of the inflammation and fibrosis that we see, and hemodynamic abnormalities in the cardiovascular system more generally. So this is the respiratory part of the infection, but clearly it goes beyond the lungs, goes into cardiovascular system. There's the diarrheal disease, the eyes, the brain, nose in terms of loss of smell as being a key sense, liver, kidneys, and then also endothelial cells and the coagulation system. So this is clearly a systemic, can have a systemic phase as well. That's been confirmed by pathology. So this is extremely important for vaccines because in a sense, there are two immune responses that we're going to see shortly, IgG, which is a systemic antibody response, and IgA, which is a local or mucosal antibody response. And different vaccines and different approaches to vaccines will create different responses accordingly. So as Dr. Ravindran mentioned about the testing, I'll just review this very quickly. There are 3 ways to test for COVID-19. And again, we can focus on the nucleic acid or the spike protein. And as we do days since onset of symptoms, we can have RNA-based tests, which is the PCR tests, which typically go 2 to 3 hours, and it's a swab test, as we mentioned. There are the antigen tests in the near term as well, and that would be a protein test by protein amino acid, typically a blood test that gives results in 10 minutes. And so these are diagnostic tests in terms of being infected with the virus, whereas the antibody tests, which are in several days after the symptoms, are serological tests, so the terminology is different, of having had the virus. So there's no one best test, and I think as Dr. Ravindran mentioned, there are many parameters, and he talked about predictive value, positive predictive value, and so forth. But there are other aspects to this. There's the timing of the test, which is extremely important, 2 to 3 hours versus 10 minutes, and it may not seem like a big deal, but I'll explain why that's very important. There's, of course, cost. There's where it is in the dynamics of the disease. So the selection of what type of test really varies along a number of dimensions, and it's not always clear whether we want a diagnostic test or a serological test. Well, it is clear, but there's no, I should say, test that fits all scenarios. And of course, there's also differences in accuracy, etc. One challenge with the antibody test problems are short-lasting immunity, different antibodies, limited accuracy, and so forth. Now, this is extremely important. We learned this in the Korea example, and I'll talk a little bit about the Korean approach to the epidemic in this regard, which we don't have a vaccine, by the way, here in Korea. But testing requires doing the follow-up. And in the United States, for example, there was a big politicization of the process, and the whole we are not testing or we are testing and not enough testing or too much testing. I mean, it was just getting out of control in that regard. But ironically, that was missing the point. Testing is meaningless without follow-up, and that follow-up being contact tracing, quarantine, isolation, and treatment. What Korea calls the 3 T's of testing, tracing, and treatment. If you don't have that, it doesn't matter if you have a test or not. And this is where the timing comes into play, as we'll talk about. If you act quickly on those test results, that's very important. Now, as Dr. Ravindran mentioned, the viral load is very important. If you do the PCR reaction, you have basically the number of cycles. And the number of cycles is a proxy for the viral load. If you need a few number of cycles, then you have a high viral load. If you have a high number of cycles that you need to get certain, you get a lower viral load. And studies have shown that there's been a correlation between mild and severe disease. And in other words, severe disease has more viral load, typically lower PCR cycles. And you remember the first doctors who died, the whistleblower in China, and the high susceptibility of healthcare workers, even if they were young, and he was just age 33. And of course, he's not the only case. Viral load may be an extremely important predictor of severe disease, whether you're young or old, and so measures to reduce that viral load are very important. So this is very interesting that Dr. Noor Hisham was talking about having more specialized approaches and not just blanket lockdowns and so forth, is that there's if you can minimize that viral load and still have the economic activities, maybe not in the same way, of course, that can go a long way, whereas a complete radical elimination of transmission, no one, I think, has ever died, we don't know, of exposure to a single virus particle. If we can modulate our approaches, social approaches to the viral load, as opposed to a kind of digital either or concept, I think that's very important, and in the spirit of what Dr. Noor Hisham was talking about. So now we talk about fighting the battle. Now, as Dr. Noor Hisham mentioned, we talk about vaccines and other measures, but let's focus on the immune system, whose goal obviously is to destroy or eliminate foreign invaders. And then we can consider the immune system in its full spectrum as having a number of characteristics. There's the innate side and the adaptive side. There's natural versus artificial, and there's passive versus active. Now, active, natural adaptive immunity would be infection, whereas active artificial adaptive immunity would be vaccination. And that vaccination goal is what we are aiming at. Obviously, this is to increase or create a secondary immune response. So the primary immune response is low in terms of antibodies. And then the secondary immune response to re-challenge by that antigen, in this case, antigen A, is greater. And it should be noted, and this is very important for vaccine development, we'll talk about some of the nuances here, that not just antibodies, but also cell-mediated immunity has enhanced secondary response. And the cell-mediated immunity may be important for the longer term immunity. Now, a very important concept that's not often discussed in the realm of vaccines is the difference between mucosal versus systemic antibodies. And this talks about or references the difference between primarily respiratory illnesses, such as influenza or the common cold, the benign coronaviruses or adenoviruses as well are in that category, and the severe infections that go throughout the body, or infections that go throughout the body, but for whatever reason don't cause severe diseases. So in other words, we have localized mucosal infections, which would be the upper respiratory tract infections, versus systemic infections that are either lower respiratory tract or even effectively in the bloodstream. ACE2 is expressed on the endothelial cells, and virus particles are found in the body pathologically. So this leads to, there are two types of, again, there are many types, but just in terms of simplification, as many of you know, there are two types of immune. There's the mucosal immunity, which is mostly IgA, which is a dimer, and there's systemic antibodies, the more effective blood-borne antibodies through IgG. And so if we do an intramuscular or intradermal vaccination, we will get basically the IgG, which is lower respiratory tract and systemic antibodies. If we do intranasal vaccination, we will get this IgA. So you can imagine a situation that you vaccinate someone, they have good IgG and they prevent severe disease, but they're not, the IgG is a large molecule. It's not in the mucosa. You can imagine these patients still getting infected and still transmitting the disease. And while the question has not been answered, as you know, at least for the Pfizer vaccine and Moderna and some of the others, the effective endpoint in the clinical trials has been progression to severe disease. So you see the statistics reduce severe disease by 94%. The question about transmissibility, which obviously requires more people and more time, has not been definitively answered in the same way as progression to severe disease. So this is exactly what is happening. As far as I know, none of these vaccines are addressing IgA and directly addressing, it may be doing it indirectly, the transmissibility issue. So I think very important, boosting the immune system is very important, getting enough sleep, updating vaccines in terms, other vaccines in terms of public health measures, healthy eating to improve the gut microbiome and to decrease inflammation, exercise, managing stress, and reasonable common sense supplements. And I think public health measures should include this kind of concept. And why do I say this in the context of vaccines? As I said, we want to win the battle, but there's also the war, and the war is more broad, as I will conclude in this presentation. And some of these non-biological, if you will, non-therapeutic measures are going to be extremely important. So what about antivirals? And then, as I emphasized, unlike miracle antibiotics, penicillin, whatever, which kill bacteria, antivirals cannot kill viruses. One cannot kill that which is not alive. There are, many possibilities, but they basically interfere with different parts of the vaccine pathway, or I should say virus life cycle, from fusion, such as monoclonal antibodies, to endocytosis with chloroquine and hydroxychloroquine, to remdesivir that affects the proteolysis, translation, and RNA replication, to other agents that may inhibit packaging and virion release. So antivirals slow down the virus, allowing the immune system to clear it. And so we may also imagine, if some of the vaccines are incomplete, that we have some antiviral therapies to do that slowing down, because it's related to viral load. And so if we can reduce that viral load, as well as then we can reduce progression to severe disease. So this is just a brief overview of the vaccines. We have viral vectors, we have DNA vaccines, we have RNA vaccines, we have live attenuated vaccines, and protein-based vaccines. I'll review these in a little bit more detail in a few moments, but I just wanted to give some summary high points of good news. Obviously, many vaccines now approved. Because this is an RNA virus, as I said at the beginning of this presentation, it's not going to be latent like hepatitis and herpes. So some of these have, very difficult vaccine targets. And unlike HIV, at least as far as we know, there have been some reports, but effectively SARS-CoV-2 does not destroy the immune system. And we still don't have an HIV vaccine. And that's probably one of the main reasons why. The bad news is, like the common cold, the antibodies might be short-term, in particular those varieties that are just in the upper respiratory tract, eliciting an IgA response and so forth. And the antibodies may vary in effectiveness. We also know, as I've highlighted, that because it's an RNA virus, it mutates. So it's like influenza, we may need vaccines every year that aim for the prevalent strains. And of course, on a sociological basis, anti-vax sentiment could be a barrier. Why is it that the antibodies may not offer as much protection? So if you remember, we talked about the SARS-CoV-2 being an envelope virus. So these envelope viruses have embedded in them, that envelope is basically the cell membrane of the previously infected cell. And embedded in that cell membrane are membrane proteins, such as the spike protein. And these, like eukaryotic animal cell cells, these proteins are typically glycated. So there's a fourth part to the virus, and that's the surface glycan sugars. And from the beginning, it was well understood that SARS-CoV-2 actually had significantly more glycan, more sugars on its surface than some of the other SARS varieties, and evading some of those antibodies, both natural, the person's antibodies, as well as, of course, those that could be induced by vaccines. So about 30% of patients failed to develop high titers of neutralizing antibodies, which those were early studies. So we have the 94% prevention of severe disease, but that may imply, well, there should be 70% prevention of severe disease, but these are not exactly measuring the same thing. You may have not really high neutralizing antibodies, but slightly lower levels of neutralizing antibodies, but it is enough, let's say, that you prevent the progression to severe disease. So it's not such a clear-cut issue. But that being said, unlike perhaps the rigid encapsulated viruses with a protein coat that have a very well-defined structure, and they don't have these glycan groups, these sugar coverings, might be difficult to produce these antibodies. So now let's shift to the green part, the transmissibility, the R0 and the RT, as Professor Dr. Nur Hisham mentioned. It was initially thought the R0 of 2 to 2.5, as he mentioned, that is now about 0.9, and that's the RT, or effective reproductive number, that changes over time as people get immunity via infection or vaccination. So the R may decrease over time. But in reality, the R is related to two things: the intrinsic factors, namely the nature of the virus, and the extrinsic factors, which is the nature of the population, the social measures. And I will talk about each of these in turn. Now, in terms of the intrinsic factors, how is it transmitted? How long is it viable? What is the incubation period? The R may change with mutation. In terms of the extrinsic factors, is defined by an equation, beta times tau, the social distancing and protective measures, and the finding isolated and treating infectious people quickly. The mean infectious period, the R changes with the situation. So the 0.9 that we're talking about is related to the situation, all the measures that the Ministry of Health and Dr. Nur Hisham and colleagues have done. But as the mutation goes, as we talked about, evolutionary towards more transmissible, that's going to the opposite. So the nature of the virus is changing as well. So let's talk about these quickly in turn. So as we mentioned, the case in Malaysia, I actually took a screenshot from his presentation, Dr. Hisham's, and I put that here. So you see that the RT is 0.9 in Malaysia. So focusing on the intrinsic factors up here, we have the methods of transmission, direct, indirect, vector, and it turns out that SARS-CoV-2 has a very wide range of transmission mechanisms: person to person, droplet, airborne, fomites, fecal, oral. It doesn't say airborne here, but I meant to include that. So it's basically quite transmissible across a number of other mechanisms. So it has a fairly significant viability on surfaces, 3 hours in air, 4 hours on copper, 24 hours in cardboard. These are referring to fomites and droplets. And this lead to droplet precautions as well as contact precautions. And that's the science, if you will, the logic behind these precautions. So what about mutation? So as I mentioned, it's RNA, it can mutate it. And there have been many studies that have shown mutations that have involved replacement of the existing strains with more transmissible strains. And these are not surprising at all. I think this could be fully expected. Now, this is a scene from Wuhan in January 2020. And when I first saw this, I was very worried, not just because there were many people there. Obviously, that was a very difficult situation. But if you look at this hospital area, to avoid more pathogenic mutation, we should ensure individual, not cohort isolation. Now, let me explain this a little bit more. It's a public health issue, but it also relates to individual practice. So evolutionarily, viruses or any pathogen or any genetic material, if you will, wants to transmit itself widely. And so if that pathogen, that virus is killing the host, in other words, it has a high pathogenicity, a high fatality, it will not transmit very readily because the host will be dying. It does not serve the virus any purpose in terms of its evolutionary sustainability to have a high fatality rate. So in general, these viruses will evolve, and that sounds like good news, to become less fatal. And that's one reason why we see some of these epidemics peter out over time. The bad news is that there is one circumstance in which viruses and pathogens more generally will evolve into more deadly strains. And that's when the transmission is easy. In other words, it's not any difficulty. There's no barrier to transmission. When does that happen? Right here. It's often thought that if we isolate patients, but they have the same disease, there's no problem. But if you isolate a virus that's rapidly mutating and you have them together and a lot of ability to cross transmit, of course, those patients will not get more sick, perhaps. They may get more sick. But that's not the point. The point is you allow for the development of more pathogenic strains. There's another circumstance that was reported recently of an immunocompromised patient that had long-lasting infection for 6 months. And during that time, in that single patient, they had 20 or so more mutations that arose. And that was, of course, a case of continuous, easy transmission. So in terms of public health, we absolutely must do individual isolation. If we pack everyone together, even if they have the same illness, we may get a situation with a very fatal mutation. So indeed in Malaysia, they have been noted. Again, this is a screenshot of some of these strains that have replaced previous strains. And different variants have different transmissibility as seen by experiments, cell culture, human airway. This is the G614 strain outcompeted the D614 strain, and some of these antibodies cross-react, some of them don't, so there's no steady rule, if you will, to whether we will be able with the existing vaccines to counter all of these strains. The key thing is to try to minimize the opportunity for this mutation. So now let's move to the extrinsic factors very quickly, the primary mitigation strategies that we talked about. Dr. Nur Hashim mentioned about balancing the economy and so forth. Here in Korea, we had a fair bit of success. So I will describe how that works. 4 parts. We intervened fast, tested early and often, contact tracing, isolation, and surveillance, and engaging the public's health. And various measures were involved in that. But remember this equation that I mentioned, that the R is equal to the beta times the tau. So there was a sort of matrix approach, beta and tau, so different approaches addressing that equation. And the most important one is tau. Tau is the time. So time is extremely important. That's where if you have a 2 or 3 hour PCR test, which means that the person doesn't wait, they go home. And then maybe 24 hours later, it's all processed administratively. They get the result. If we're in an ideal situation, that time thing, because of the exponential nature of this growth, is very critical. So these are not new strategies. Obviously, Isaac Newton developed a calculus, which is not boring, in my opinion, by the way, isolating from the plague. And this is an old Spanish influenza document. So the same strategies are similar. So we're going to talk quickly about vaccines. And we have several types. We have classical subunit vaccines, which are basically the protein, and that's done through that protein is taken up by antigen presenting cells. Some of the disadvantages are it needs a booster strategy and short memory, and there are lots of examples of this in development. There's the inactivated virus, and this is also a very classic approach, was used in polio, and the live attenuated approach in the virus-like particles. But the most recent versions, which are the most common that we've seen, AstraZeneca, J&J, Sputnik, and so forth, are recombinant viruses that basically take existing viruses and inactivate them and put the spike protein in there so it produces that, mimics natural infection, maybe not exactly the same target, a strong memory, cannot revert to natural disease, and some of the other disadvantages is that if you have been infected by that artificial virus, if you will, the vector, that will lower the efficacy, and then you can potentially have recombination with other viruses to create some problems. And then the most recent one is these RNA vaccines, which are basically not viruses, they're just liposomes with RNA. And very important, they're easy to modify. So if we get a variant, we can create very quickly these vaccines just by changing the RNA. It doesn't clear any disease, but it tends to have a short immune memory. And again, this is not really affecting the disease process. It's not creating this sort of IgA response. It's the systemic thing. So it's no surprise that they affect the development of severe disease. I would not be surprised if these RNA viruses, vaccines, sophisticated they are, do not prevent transmissibility. So again, transmissibility versus fatality, we have mostly IgA and mostly IgG. I think these are open questions. So we might see eventually in the future, especially if we need to have multiple vaccinations, intranasal vaccination. So finally, I want to talk about winning the war. And I'll talk about 4 key issues: epidemic to endemic, chronic to acute, stochastic to deterministic, and treatment to prevention. So there is a bigger war going on, as Dr. Amin mentioned. So let's talk about some mega trends in medicine related to this. So there is the hope that, as I think I've mentioned, is not really possible of eradicating COVID-19. Now we have the example of smallpox, but I talked about some of the biological reasons as well as other reasons. So biologically, it's an RNA virus, so it mutates. The immunity is not as strong. It's the nature of the vaccine. Sociologically, we have the anti-vaxxers. So we defeated smallpox and polio during an era where we didn't have as much disinformation and sort of distrust of science, which is very tragic, but that's just the reality we live in. And likewise, people are against social distancing and so forth. And of course, pockets in terms of epidemiology, if we don't roll out the vaccine in a broad manner. So I think the consensus is, not just my opinion, that this will become an endemic disease. Eradication is very difficult. In fact, that's the exception rather than the rule. The other important trend that has been exposed by COVID-19 is the conversion of chronic diseases such as obesity, hypertension, cardiac disease, most notably, into acute conditions. I think this is a paradigm shift most people are obviously aware of, but the implications are not well appreciated. What do I mean to say? So for example, you have obese patients have a significantly higher chance of getting severe COVID than non-obese patients, all other things being equal. Obesity is not an acute condition. People do not die of obesity in 2 weeks, right? It's a long-term or chronic condition. But if you have COVID and you have obesity, that obesity can render your susceptibility to severe disease. So you do indeed die of obesity in 2 weeks. In other words, it converts chronic conditions into acute conditions. And why is this important? Because one of the reasons why we have so much chronic disease, 6 in 10 adults in the US have chronic disease, 4 in 10 have 2 or more, and obviously the case in Malaysia as it ages, population and so forth, lifestyle aspects proceed. The same thing all around the world in many countries. These chronic diseases are treated in a not the same sort of intensity as something you would die 2 weeks from now. People don't address obesity as urgently as something like having a car accident and epidural hematoma. Now, obviously, I'm making extreme comparisons here, but COVID has changed the landscape, has converted chronic disease cases into effectively an acute situation. I forgot to mention diabetes. Then we are having another mega trend in medicine from the stochastic to the deterministic. What do I mean by this? Well, we have diabetes, we have obesity, and we have various statistics that someone may get some problems from that. But we don't really know what those are. But now with more digital healthcare and sensors, and this is the digital health cluster we're working with CREST and Dr. Nouri Sham, we can, and artificial intelligence, of course, we can convert some of this guesswork and probabilities into more deterministic information so that the chronic diseases can be managed more effectively. And that means we shift from treatment to prevention. So when someone has obesity, of course, we want to reduce that. When someone has diabetes, we reduce that. But typically the medical system is focused more on the acute manifestations. And if something is not dire, then we don't take care of it as urgently. But if you do have diabetes and there's COVID all around you, then that's a dire situation. Oops. So every challenge is an opportunity. My prediction is COVID-19 will evolve into an endemic disease. We know chronic conditions are risk factors, converting these chronic conditions into acute diseases. If we can truly prevent such chronic conditions, then we improve health broadly and also reduce the burden of COVID-19. That's the war that I'm referring to. How do we do that? Leverage the full potential of digital healthcare, comprehensive preventative care. COVID-19 effectively becomes like a common cold, and vaccine strategies can focus on regular vaccines for young and highly mobile against transmissibility, perhaps the nasal vaccine, and the high-risk individuals getting vaccines against the severe disease. So we have to think of a more comprehensive approach. And life will need to be different. This is extremely important. Everyone talks about going back to normal. But 200 years ago, even 100 years ago, most cities had open sewers. And of course, cholera and dysentery were endemic. Now, I'm not saying we go back to open sewers or we have anything like that, but we have implemented certain minimally technologies and virtual technologies and other methods that minimize spread of this sort of disease. Maybe not as drastic as eliminating open sewers and not as drastic as lockdowns, but some of these measures should persist. Life is not the same as it was. Urban life or life in general is not the same as it was 200 years ago. So we will have some differences. And isolating, as Dr. Noor Hisham, selectively, what should be those things in terms of public health that we continue? I remember when I was in the New York City subway in the 1970s, I saw signs, no spitting. And people weren't really spitting that much. And of course, they don't really do that much now in New York City in the United States. But apparently back in the 30s and 40s and 20s and whatever, spitting was very common and tuberculosis was very common. So those signs about no spitting were related to obviously tuberculosis. And now we've had a cultural change and people just don't spit as much in public as a matter of culture. So things will be different. So that music that came up was from my book called Waves. Actually, it's not my music, but it was referenced in the book. And the character Thomas talks about war, not an ideal metaphor. Doctoring was very much like doing battle. Tenacity was required to defeat an enemy unrelentingly dedicated to killing their patient. To this end, he remembered listening for inspiration to the soundtrack from Barry Lyndon, The March of the British Grenadiers, a famous military march. In medical school, preparing for an exam, he would begin the day at dawn with a rousing turn of that storied music upon the record player. And then we can, just for a few moments, and then on that note, I will end. Thank you very much, and please take care. I can be reached on LinkedIn as well as via email, ogangarel@gmail.com.
Thank you so much, Prof. Gurel, for that highly engaging and informative talk. We are, again, very limited with time. So may I ask you just one or two questions?
Sure.
What is the current consensus, if any, on vaccination for those who are positive or have been infected with COVID?
In the past.
Now, do we know that, do we need to
well, I think there are two
when
things.
do we vaccinate them? Yeah.
Yeah, so there are two things. One is previous infection and one is concurrent infection. So in general, whether it's COVID vaccine or not, and of course there may be some exceptions, but in general, as a matter of policy, we are not, it's not advisable to vaccinate people who have an active infection of any sort, right? So they ask if you have a fever and so forth. So let me interpret your question in terms of previous infection.
Yeah.
And in terms of previous infection, there's anecdotal evidence that people have more side effects and sort of a more vigorous response to the vaccine, which might be a good thing. I don't think there are any studies that show that people are contraindicated if they've had previous infection. And I think the strategy in the United States has been to vaccinate all healthcare workers, and many of them have actually had infection and documented and so forth. There are no exceptions. So I believe the feeling is to still vaccinate those people.
Is there a time period between the time they had infection and vaccination? There is.
Well, I cannot quote any formal recommendations, which I don't know are there, but just from kind of medical practice, if you will. If someone is not actively have an infection, in other words, they're afebrile and don't have other symptoms and so forth, and PCR negative, although that may not be a criteria. I don't think we have to test people PCR wise all the time, obviously, to get vaccine, but say they are negative as a result of having a fever and symptoms. If they're basically disease negative, I think that that's okay to give the vaccine, given the current situation. We may learn more in terms of those who have been previously infected, but I don't think the data is out. So I think the advisory, as I understand it, is basically to be agnostic with respect to prior disease status.
Okay. Second short question. With this many vaccines in the market now, I mean, many types of vaccines, is there any reason for preference for one vaccine over the other? Let's say for the RNA vaccine over the vector or the live attenuated, based on race, disease, or anything like that?
I don't think that there are any significant differences in terms of, well, let's look at the basic efficacy. My sense is that basic efficacy, focusing on severity, as I said, not on the transmissibility, which is an open question, and I still think is very important, and we need to have vaccines that address that. Again, maybe intranasally, but that's a future generation of vaccines. Okay. But in terms of primary efficacy, my sense is that they're all fairly similar. You know, the 80 to 90 to 95% prevention of severe disease. So the differences are related to two factors as I see it. One is practical factors about cold chain supply, delivery, availability, and so forth, which are very important because if you can't vaccinate somebody because of practical limitations, it doesn't matter how efficacious it is, right? And the other one is relative to the new variants. And I think that that's still an open issue. There was a concern, if I understand correctly, AstraZeneca was not working against as well or against the South Africa variant. And so I think that as that develops, but I think it's really hard to predict. I mean, as Dr. Nur Hisham mentioned, you're already having two major variants coming up in the past few months. And so it's a moving target. So choosing the virus or the vaccine on the basis of what the variants, unless you really have a situation like in South Africa, where it's clearly that's what the situation is, I think is very hard to do. So I would be choosing those vaccines primarily on availability and practical concerns. And this is extremely important because I think because of the whole mutation thing, well, let's put it this way. With the testing, people came to the realization that the testing alone was not that important, was not the only solution. Testing plus the follow-up, which was the tracing and the quarantining, et cetera, and the treating was the key. Just testing is as we learn in medical school, the attending asks you, why did you do that test? And you say, well, I don't know. And they get angry at you. Well, they tell you, we learn from beginning of medical school, you only do a test if it changes your clinical management, right? So if nothing is happening as a result of the test, I mean, what's the point? So we learn hard lessons that testing plus expeditious testing, expeditious management, in other words, tracing. What I think is going to be important with vaccines is expeditiously delivering them quickly across the population. Why? Because if the vaccine is smoldering, right? I mean, the virus is smoldering, and new variants are being developed that escape the vaccine or become more pathogenic or more transmissible, what's the point? You see? So vaccine is important, but a logistical effort, and we're talking, you know, it's just like in war, you can have very powerful weapons, but if you can't bring the ammunition there, you lose, right? Logistics is very important. The quartermaster may not be the most glamorous general, but they're very important. So I think just like with the testing and expeditious tracing and treatment, the vaccine and expeditious rollout are going to be important. So my summary would be the practical aspects of that and getting that vaccine as quick as possible, whether as opposed to a 2% better in terms of efficacy, is going to be more important.
Roger. Right. Prof. Gurel, thank you so much for the answers.
Thank you.
For those questions, for those participants on Zoom, Prof. Gurel can still answer the questions if you wish, sir, through the questions that we pose there. So, but unfortunately, only participants who came in through Zoom can read the answers
yes.
from the
right.
Yeah,
Not the YouTube.
you can do that. Okay. So
Yeah.
Okay then.
Well, I think
so
we're late on
so
time.
Huh?
I know Mr. Pak is waiting, so
Yeah, he's waiting. Yes.
Well, thank you very much for the kind invitation. It was my honor and pleasure. Please take care. Thank you.
Thank you. It was our pleasure. So our final speaker for today is Mr. Stuart J. Vanderpack. Mr. Pack originates from the UK, but has been in Malaysia for over 25 years. Has held several C-suite positions, all in healthcare management. These included CEO of Subang Jaya Medical Center, CEO of Gleneagles Hospital Kuala Lumpur, and CEO of Prince Court Medical Center. Mr. Pack is now managing his own company called Medical Opinion Asia. It's a digitally driven cyber health service supported by over 80 medical specialists. There's clients which include major insurance companies, law firms, and the community, both locally and internationally. With a keen interest in preventive healthcare, Mr. Pack is also looking at medical technology developments and applications in healthcare delivery, developing the networking potentials for maximizing digital data transfer management, and focusing on preventive healthcare through Internet of Things technologies. Mr. Pack will share with us his ideas on the use of technology to bridge the gap in medical services in the pandemic. Please welcome Mr. Stuart Pack.
Okay, well, good afternoon, everybody, and thank you very much to the organisers for the very kind invitation to be with you all this afternoon. We just heard two very interesting speakers going into great depth in a clinical and scientific way. I'm going to do something a little bit different from that. I'm going to take you into the bigger world, but also to share with you some of the aspects of change that have occurred since COVID-19 has hit our shores. We read in the papers a lot of people who have lost their jobs and are now looking for new opportunities, and there are some who are very entrepreneurial, will find those opportunities. But on the other side, COVID-19 has offered a lot of opportunity for development, taking existing technologies and developing them into bigger and better technologies, but also looking at new technologies altogether. So what I'd like to do is to share with you this afternoon some of my perceptions and some of my feelings of where we have come from, where we're going to, and where some of these opportunities actually lie. I must say once again, the last two speakers were so interesting and very deep. This is really quite a different kind of approach altogether. Anyway, let me take you through this. First of all, I think we have to accept this is not the first pandemic, nor will it be the last pandemic. So what we must be doing is learning as we go along to make sure that hopefully we're better prepared for the next pandemic. There are some barriers, however, and we've heard one or two of these being mentioned just now, but you know, poor communication is a huge barrier. Lack of transparency is another, lack of willingness to accept and change And of course, we have self-interest and or denial. And it's not, since maybe a few weeks ago, we were seeing one major country who was clearly in denial of what was going on. Whether correctly informed or otherwise, that was the way it was coming over to the public. And so this is one of the great problems. But let's take the negatives to one side and let's now look at the positives. And of course, innovation and creativity is what everyone has been looking for. But the world has changed. And as we go around in our daily lives, we're now seeing things like robots in hospitals, people in PPE and in the streets, robots in the streets, robots in shopping centers, airports. Temperature scanning has become an everyday part of people's lives now. Social distancing, of course, and we heard just now how very important social distancing is. And of course, here's one business that has really emerged. As people have been locked down and are scared to go out or don't go out or can't go out, of course, a new business has come up, and that's the business of courier, of delivering goods to houses, to condominiums, delivering food and so on. I think at the last count, there are over 100 new companies now merging into this area. So the key areas that I'm looking at for some of the real innovations for COVID-19, satellite monitoring, robotics, health sensors and apps, big data and facial recognition and so on. And I'm going to pick up on just a few of these as we go along. Let's take satellite imagery as a start. Satellites obviously have been around for some time, and their ability to capture images or capture other details has been very valuable to us as we look at what's going on in the world, scientists and so on. Let's take a look at one, for example. This is Shanghai in China, and it shows basically population, and it shows how population is spread in different areas. And so for disease control, this is very important, so one can see where the populations are and where the target should be. This satellite image of Italy was taken 1 year apart and shows the different gases that have been released into the air, and showed quite clearly that during lockdown, fewer gases were being emitted into the air. And we heard, of course, that those very polluted cities around the world became a lot clearer during the lockdowns, as did water become clearer in some of the cities with water. And of course, the other things we get from satellite images are changes in the terrain. And here we see the terrain one day on the left, the next day there's a new hospital or a temporary hospital that has been built. So it enables one to look at the changes in the terrain. Now, robotics have been playing a huge role, and those people who are building robots, designing the AI functioning of robots are having a field day right now. This is something that everyone is going to come up against at one time or another. Up on the corner here, we have this robotic dog, which has already been in Singapore, running around looking at how many people are still outside when they should be locked down. Of course, it's changed a little bit now. But here's one application that, of course, we never saw before. We got warehouse robots, delivery robots. We got bedside robots as well, assisting frontline staff. We even now have a robot that's taking swabs. So robotics as an industry is really forging forward and is having huge opportunities to go into innovative areas. Health sensors and apps is another area. And if I just pick up on apps first, the contact tracing apps, quarantine apps, symptom apps, everyone has now got used to. Before COVID-19, those people who are looking at apps would only do so if they're really interested in their apps. Now it's a necessity. And with My Sejahtera here in Malaysia, of course, almost everybody who goes out now is going to have this app and is going to be using this to get into the shopping centers or even hotels and anywhere that is public in nature. The other apps, of course, are apps of information or apps collecting data or apps that are providing patients with information about themselves, having worn some kind of a monitor. So I'd like to just now move on to Wi-Fi connected sensors for apps. Now, there are so many different types of sensors that are now being developed. Arm sleeves, wrist monitors, contactless in-bed monitors, epidermal patches, and so on. Let's just look at these in their totality. And we see that almost every part of the body now has something that is wearable that is going to pick up data from the human body. Now, why is this important? It's important for two reasons. One is it's important for the individual who wants to know something about himself. He may want to know his temperature, he may want to know his blood pressure. But more importantly, this data that can be captured is also going to be transmitted back into a smartphone. It's going to be transmitted then from a smartphone and tablet or PC through a modem, and will go and be transferred into store and of course up into a cloud. Now, this is useful for the individual, of course, because they're going to know a lot more about themselves, but it's also going to be very useful for somebody else who's capturing that data. Whether it's an official capturing of data or whether it's unofficial, both ways data is being captured by somebody, and that's going into this big data bank. And I'm going to be talking about big data near the end of the presentation. That data is being transferred, and I think more than any time before, we are now able to collect so much more individual data on individuals as well as groups of people as well. Health sensors, of course, are helping in the healthcare environment as well as the personal environment as well. So from heartbeat to heart rhythm, heart rate variability, and so on, particularly for COVID-19, blood oxygen saturation has become a big area of concern or a big area of focus. Skin temperature, of course, we know is being big. Core temperature, a little bit different from skin temperature, where there's just a calculation of the skin temperature for the core temperature of the body. Sleep patterns, snoring, breathing, ECG, photoplasma thermography, accelerometer, geographical positioning, all of these things can now be from the body by some kind of wearable device. But it's going to help a host of different people. And of course, you've got your exercise walking activities as well. Now what we're seeing developing as being patches and tattoos for further monitoring and treatments. Interestingly, the patches that we've seen at the beginning tend to be more to take information from the individual, pass it through a Wi-Fi or a Bluetooth into a gadget of some sort. That is becoming more complex now, and we're getting into microneedles and tattooing. Tattooing basically does the same, but just puts something embedded into the skin, which is going to transmit data. But the microneedles are going to not only transmit data, but they're going to be used for treatment as well. So there's a new emergence in these areas, and then we're going to see more of this in the future. So equipment modification is something else. And whether it's existing or new equipment, we're seeing now care robotics. Drones, of course, are being used now for security, monitoring, and delivery. There's a huge development now of drones. Vital sign monitoring. You don't have to move far now to see different monitors in different aspects of life. Walking into a hospital, you'll have your temperature taken. Walking into a shopping mall, you'll have your temperature taken. What I find interesting is in a shopping mall, your temperature changes quite rapidly from monitor to monitor. But I guess that's something to do with calibration. The emergence of protective equipment or personal protective equipment, without any doubt, has seen many changes being made. And of course, this has become very big business as well. Portable dialysis, telemedicine, and remote monitoring is helping clinical staff read data from remote areas, and also helps to keep clinical staff a little bit at a distance away from their patient who may be highly infectious. Portable ventilators, and I'm sure you all know a lot of work has been done now on different types of ventilators to help patients with COVID-19. Point of care ultrasound is something that I've particularly become interested in. And now, as we see with COVID-19, the problems of the changes of lung tissue, ultrasound is becoming more and more important, and particularly point of care ultrasound. And we are actually doing a project at the moment, and we've got some devices in the triage area at one of the quarantine centers here in Malaysia, where they're doing an ultrasound of every new member of the patients that come into the triage center, so that they have a baseline of the lung before they then either are cleared or they then develop their COVID-19. And of course, face masks have gone through a lot of change, and of diagnostic kits we heard a lot about just now. There are many different diagnostic kits available on the market. These are all big business opportunities that people have taken a hold of and are forging forward quite rapidly. It is quite interesting to see how these new opportunities have come out as a result of COVID-19. Then, of course, we got on a bigger scale. We got the temporary quarantine centers that are being built, quarantine hotels being set up. Temporary hospitals in different parts of the world have suddenly emerged, and we saw in China probably one of the first that was being built in a number of days. So the skill set has changed to be able to rapidly develop a building to meet a particular cause. And in this reason, it was for COVID-19 to get patients in there either to be treated or for quarantine. Mobile and drive-through screening centers have become something that we're seeing a lot of around the country and around the world. Vaccination centers are now going to emerge. Now, hand disinfection is interesting because we know the importance of cleansing our hands and disinfecting our hands, but have you noticed how many different types of dispensers there are now around as well? Another emerging industry just in hand disinfection. Facial recognition particularly has been developed in countries like China and Russia, where they're able to recognize people on the street. It's a little bit frightening, I guess, to know that this is being done, but we hope it's being put to good purpose. The use of QR scanners. Now, before COVID-19, how many people were really clear about what QR scanning was all about? I think now almost everybody is knowing what QR scanning is about, as 3D printing is coming in with even some of the face masks which are being developed on 3D printers. Now, let me just bring you back again to data. I talked about the different means of collecting data, and there are so many different ways of collecting data, whether it's on wearable devices, whether it's on scanning when you go into shops or any other public area. What's happening to all this data? And a lot of people are concerned that this data is going to be abused. We know that data does get used for marketing reasons or to try and target particular people for particular products. But let's look at the more positive. The big data that is now being collected as a result of the various research works, data from patients, data from hospitals, this is all helping with the identification of infected cases. Travel history and details, of course, we saw at the beginning of COVID-19 how quickly it was spreading around the world, because we were picking up on how quickly the infection rates were in different countries. This was being shared. We were able to see maps and to see how quickly each country was reacting to COVID. Unfortunately, we didn't see it as quickly in some, and that goes back to some of those problems of perhaps lack of transparency or perhaps a little bit of denial. Fever symptom occurrences, identification and movement of the virus at early stages, very important to see how COVID was developing and where it went from country to country. And of course, that came a lot down to travel and the way it's so easy now to travel around the world. Identification and analysis of fast-moving diseases is another thing that big data has been used for, as well as information of local movement during lockdown. We get a lot of information on the news of whether the various policies of movement have been adhered to. This information is constantly being looked at to see whether or not the lockdown is working and whether or not people are adhering to it. So again, this data is being used to try and contain, where possible, the movement and to contain the COVID-19. People entering or leaving infected areas, well, we have different controls. Again, we have state controls here, district controls, but again, through the data collection, we're able to see where people are actually moving to. And this has a very important impact on the way we control COVID-19. And faster development of medical treatments, of course. And the more data there is, the more science can be done on that data to try and come up with the solutions that are needed. And of course, geographical movement. And I put geographical movement at the end there because I think one thing that is certain with COVID-19 is because of the geographical movement that this has been spread around the world so fast and has moved at a pace which we've not seen before, more because we didn't have the data before. But now we're able to track what is going on. We have a better sense of what's happening, so a better opportunity to try and do something to control it as well. So in all, big data, whilst we can be a little concerned that someone has all this data is being put to good use as well, and will continue to be collected. And in the digital environment that we're in, almost every day, something we do is being captured by somebody, and that is going to be used in one way or the other. So it's with that I'd like to just close this and say that my presentation has been not so scientific as the last two, but has tried to emphasize on how technology is developing. People are taking the opportunity to innovate and create from a disease like COVID-19, but this gives great hope for the future so that hopefully we can work together and develop a healthier environment. So I will bring the presentation to a close at this point, and thank you for listening.
Thank you, Mr. Peck, for taking us through the present and the future of what's available and what we can use in terms of pandemics and also medical as a whole. Right, I have one question for you. Would you have any suggestion on which technology or how we can use technology to tackle anti-vaxxers other than the obvious educating them, proper channeling of the right information?
Well, that's a big question. The anti-vaxxers, that's a whole education process.
The usage of big
data. It can only be done through education. And I think this is something else we have to learn, is how to educate and how to communicate. And I'm not sure we always do that in the best way. We often put a lot of diagrams up, television puts out various pieces of information, but I don't think we're educating well enough. And I think the anti-vaxxers are that way because they've either been ill-informed or they don't have the right information in the first place anyway, or enough information, shall I say. So I think it comes back to education, and there needs to be a real focus on that.
And which technology is best used for this?
Well, it has to be, social media is the quickest way to get to people, but that has to be done so carefully. We have the digital means of collecting the data, but to deliver it to people and individuals, I think social media is still going to be probably the fastest and best way to do it if it's done in a controlled way.
Yep, I agree, sir. With the advances that we have in relation to COVID-19, do you think the future of medicine will move faster towards IT and big data and technology?
I think actually it's already there. Technology will continue to be developed, but what we're learning more is from big data, we're able to plan and strategize a little better than perhaps in the past. The problem is overload of data. And this is always going to be an issue of making sure we capture the right data and use it in the correct way. Technologies are going to become more digital. I think robotics are going to play a bigger part in medicine. The role of individuals is going to change. And as we get into networking of data and networking of information, we're going to be able to help more people in wider areas, and particularly in rural areas as well. I, for one, am more interested and very excited about the opportunity of taking healthcare into the rural areas, not just Malaysia, but in other parts of the world, by using technologies and networking.
Right, with that, we thank you again for your very, very thorough and very interesting presentation, sir.
Thank you.
So, ladies and gentlemen, we have run over time. We are sorry about that, but I hope you have found the talks over the last 3 hours or so informative and useful. Our heartfelt thanks to all the distinguished speakers for their presentation and also sharing of their expertise. We look forward to listening to them again in the future, of course. On behalf of the organizers, the Malaysian Armed Forces Health Services, the DSA, NATSEC Asia, and ROC Exhibitions in Berhad, I thank all of you for participating with us today and staying back with us, and sincerely hope that you have benefited from all the talks. I do hope that you can join us again in the future in the MMC webinars. For those of you who are thinking of participating in this year's Malaysian Military Medicine Conference on the 5th and 6th of April, I hope to see you there. Till we meet again, stay safe and stay strong. I'm Dr. Rosman Abdul Rahman, bidding you farewell for today. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rosman. Ladies and gentlemen, we have now arrived to the end of our event today. We apologize for the overtime and thank you for your attention and patience. A few last housekeeping announcements before we end our webinar session. For medical doctors who have registered earlier and would like to claim their CPD points, don't forget to scan the QR code on display on your screen currently. Secondly, for all registered participants, your certification will be emailed to you later. And last but not least, to everyone here, kindly complete the online survey as you log out from this platform. For those who have more questions, perhaps you can email the respective speakers yourself. Some of them have shared their email, so please do so. So thank you again to all honorable speakers, Ministry of Health Malaysia, and last but not least, the Organizing Committee, Malaysian Armed Forces Health Services Division, the Defence Service Asia, and ROC Exhibitions in Berhad. With that, have a good weekend to all. Thank you.